Good afternoon, good evening. Welcome. This is Stan Conte from Conte Sports Performance Therapy in Scottsdale, Arizona, with episode 5, Shoulder Instability. Just wanted to quickly give my disclosures again. I'm a consultant for Major League Baseball. I'm the owner of Conte Sports Performance Therapy in Scottsdale and Conte Injury Analytics, a consulting company. Today we've got some great speakers on shoulder instability, which is a really difficult topic. We're going to go into some depth with this over the hour and a half. I wanted to talk a little bit about CEUs again for people maybe just joining us for the first time. The CEUs will be provided at the end of the series based on 2 CEUs for athletic trainers per episode. Just make sure you do the survey at the end for the BOC requirements. Also, all the videos are on our website, conteperformance.com. Typically, we put the latest one up by Friday, so you can go and take a look at those, again, on conteperformance.com. Today, we're going to do a flash poll again. We did this before. Worked out pretty well. Nancy has just put that up. It's a poll really to see if we ever get back to normal in the United States again, how are we going to, do we want to continue these webinars? Sort of a yes or no situation. And if it's yes, we'd like to know if you wanted to do it once a week, every other week, once a month. And don't think that you should continue once MLB starts, that's fine. And then go ahead and hit that as much as you can. It's just an interesting non-scientific poll, but it actually helps us quite a bit to know what we're going to do, hopefully in the next couple of weeks when baseball restarts. So, all right, our first speaker is Neal Elattrache. And he is the team physician for the LA Dodgers and the LA Rams. I think this is the new logo for the LA Rams. Really, I guess. Neal Elattrache, University of Notre Dame undergraduate, University of Pittsburgh Medical School internship in general surgery. I'm going to be a thoracic surgeon at one point, orthopedic surgery residency at Pittsburgh. Sports medicine fellowship by Kerlan Jobe Orthopedics. Really, his mentor, Frank Jobe, had his fellowship with him. He's authored 40 textbooks, 100 research journal articles. I got to believe that's low. 10 orthopedic instructional videos, and given over 317 lectures at national and international orthopedic conferences. He's a team physician for the Rams and the Dodgers. Also a consultant to the Kings, Lakers, Ducks, and served as a senior surgeon on site and surgical support for USOC in the 2008 Beijing Olympics. He's on the board at Kerlan Jobe and a variety of different things. He's the program director at the Kerlan Jobe Fellowships. All those good fellows that come out of Kerlan Jobe are his responsible. I talked to his wife, Tricia, and she gave me this. He's one of the most powerful men in LA sports. He's the most powerful man there is, according to her. He's been named over and over, but I thought the one that was the most poignant was the Hollywood Reporter, which is a big newspaper in LA. Had him as Hollywood's top doctors. Here are 2 of the normal people he normally operates on. Got them both in one day. So, Neal.
Thanks, Stan. Probably the thing I was luckiest enough in my career to do is with regard to sports and taking care of teams was the combination of you and Nick and Nancy Patterson all working at the same time that I was there with the Dodgers. And I learned more about baseball and baseball sports medicine from you than maybe anybody other than Frank Jobe himself. And so that I was very fortunate to be there when you came in about 2006 and you assembled quite a team. It taught me a lot about the day-to-day care of these athletes. The other thing I want to say before we get started is, Stan, you created this webinar series, and it's become quite popular. I've spoken to a lot of people since you've started it, and you deserve a lot of credit for doing this. This isn't easy to do it, and to put it together like this is really a credit to you. I hope that this remains a way for people across the country that are interested in this sort of thing to continue to learn and stay up to date. I think this is a great format. So my topic today that Stan asked me to talk about is on, quote, instability in the shoulder in baseball, and instability means some different things whenever you're talking about the baseball shoulder than it might with regard to traumatic instability and some of the other things we talk about. Certainly you do get traumatic causes of instability in the baseball shoulder, but we're going to go through some of the things that are unique to baseball with regard to instability. So everybody here has heard about internal impingement. This actually was a term that was given to the unique process that happens inside the shoulder with the extremes of rotation and abduction. And Frank Jobe and Bernie Morey from the Mayo Clinic, who was visiting Vero Beach at the time, like he usually would during spring training, and I were sitting talking about some of the things that we were writing about at the time with regard to damage to the articular side of the rotator cuff and to the labrum. And Frank Jobe and I were talking about this abutment that would occur at the extreme of external rotation. And Bernie Morey then, just off the top of his head, so he said, so this is a impingement, but instead of being an external impingement on top of the rotator cuff under the acromion, this is an internal impingement. And the term internal impingement was born. This is a mechanical abutment of the undersurface of the rotator cuff and posterior radial tuberosity, and where the rotator cuff attaches, with the posterior glenoid and labrum. And it occurs with the arm abducted and externally rotated, but it can occur with a perfectly reduced humeral head. So you don't have to have abnormal translations for this to occur. You just have to rotate it far enough and it's going to occur. Here's a otherwise normal shoulder with an MRI scan taken in abduction, external rotation, and you see the rotator cuff draped over the back of the glenoid, and this is in a normal shoulder. So with baseball, though, you get into this position over and over and over again, and what we've seen recently is the pathology that occurs in the shoulder and elbow from the kids that really started doing this almost as soon as they could walk. And that happened basically at the turn of the century. We started to see this phenomena, year-round baseball, really starting to explode. And Stan wrote about this when we were looking at this explosion of Tommy John type of injuries and surgeries that we started to notice right around 2014, 2015. That has continued. But what you see now is this pathology. And I'm going to talk about some of the things I'm seeing lately over the past few years that we hadn't originally seen, that probably is also related to this explosion of repetitive pathology that occurs from the time that these people are kids playing year-round baseball. So with this repetitive contact between the rotator cuff and the glenoid, you see this compression that occurs between the tissues, and that causes abrasion and shear. You also see hypertorsion. So, just if you were to take a paper napkin or anything that you can turn into like almost like a rope type structure and rotate it and then scrape it against another surface, you'll see that you can easily cause damage to those structures. So when you put torque and rotation on these tissues and then you abut it, cause abutment against another hard surface like the glenoid, you really do cause a lot of damage that is irreversible. You can, and don't forget, you can also have traumatic injuries to the shoulder superimposed on this. So just because you're a thrower in baseball doesn't mean that you're immune to having the same type of trauma that can occur, that can tear the labrum anteriorly, posteriorly, or superiorly. And so, those problems then can arise because either the person was playing another sport or he got injured diving into base. I've had most recently one big time ace for a professional baseball team that completely dislocated and tore his rotator cuff, tore his labrum, tore his capsule, because when he was rounding first base after he was getting on, he was diving back into base and completely destroyed his shoulder. And that took me a lot of surgical repairing to get that thing back in action. So those things can occur. Don't forget about that. Here's an MRI scan showing some of the different types of pathology that we see, and you can see that on this one you got a big superior labral separation. We got some bursitis sitting on top of the. Let's see if I can get a pointer up here. That fluid signal, that light fluid signal sitting on top there, that's bursitis. This is the superior labral separation. It's got an inferior capsulolabral separation. This is all from a traumatic injury. So this goes back to the continuum of pathology that we see in the throwing athlete. And so if you look over on, the problem we think begins on this side, and it's with those positions that the shoulder gets into with hyperangulation. Hyperangulation is when, if you take the arm up into, if you guys can see me on the screen, angulation we call is sort of horizontal abduction. That's hyperangulation. Combine that with external rotation, now you've got the kiss of death, because that now you're scraping the undersurface of your cuff and the posterior humeral head on the glenoid rim. And if you look, and I'm sure that Joe is going to talk a little bit about looking downstream for problems that are going to reflect itself as problems in pathology in the shoulder and the elbow, muscle weakness of the core, and inappropriate positioning of the hips and trunk, and all that leads to inappropriate positioning of the scapula. Once that happens, then you get this with hyperangulation, external rotation, with the interplay between those problems, that produces this progressive microtrauma that happens to the tissues, the labrum and the rotator cuff. And that superimposed on this other thing I'm going to talk to you about. And I think Stan is going to like this discussion, because this is one of those things, like I mentioned, we're seeing what Stan was talking about with seeing the increase in elbow injuries in these kids. The chickens were coming home to roost. These were the generation of kids that were playing year round and overusing. This is what I'm seeing with regard to the shoulder with that same problem and phenomena. This problem here makes the internal impingement even worse. The thrower's dysplasia causes problems that create internal rotation deficits and loss of total arc of motion, so total motion arc loss in these players. And those are really tough shoulders to take care of. And so all that issue beginning back here then leads to this enhanced internal impingement. I'm going to talk a little bit more about thrower's dysplasia a little later in the talk, but this is posterior glenoid bony deficiency. When these kids are growing up and throwing a lot, what happens, they get a sloped version to the posterior glenoid, the bony glenoid. And so you almost get a deficiency of the posterior bony glenoid. Well, that is compensated for by a very thick, firm chondrocapsulabral complex. So where the cartilage of the glenoid fills in where the bone should be, and the capsular attachment, labral attachment to the back part of that gets very, very thick in order to try to stabilize the back of the shoulder. And sometimes external to that, with the capsular tension on the growing and maturing glenoid, you can get this ossification, which used to be called the Bennett's lesion. And what this is an ossification at the traction point of this really tight, thick capsule on the posterior aspect of the glenoid. And all these problems then increase the internal impingement. So this is what a normal glenoid in the axial view would look like. You know, this is the anterior part, this is posterior, that's the posterior labrum, and a relatively nicely developed but thin posterior glenoid rim. This is what happens in this phenomena. You get deficiency of the bone in the back of the glenoid. So this bone dives off. You don't have this nice sloped sort of triangular shaped glenoid. You get this weird shaped glenoid where the bone ends abruptly, but to compensate for that, you get this big wedge of chondrocapsulabral tissue that forms here. The posterior capsules in these people are very, very tight, and they lose internal rotation. But because, like I said, this enhances the internal impingement. Look what happens when this shoulder rotates. So in this view, it's going to rotate. This head's going to rotate counterclockwise. Look what's happening. This cavitation of the back part of the humeral head is this cavitation is caused because of this impingement on this big wedge of tissue back here. And as the players get a little bit older and advances, this causes a lot of damage to the back part of the humeral head and to the rotator cuff, and leads to a dynamic form of instability that we're going to talk about that affects the rotator cuff. This is now, you take that was a teenage kid that we were looking at there. Now we look at when these people get a little bit older. Now we're starting to see them in minor leagues and major leagues. And this is the kind of cavitation and now cystic formation that we see from the repeated abutment of the posterior humeral head on this big wedge of tissue back there, okay? So that's the newer thing that I've been dealing with over the past few years and trying to come up with a good way to treat that, which can be very challenging. So we get back to our continuum, and what happens is as the internal impingement continues and progresses, you get pain and limited performance plus or minus instability. So you may not get true instability of losing the centering effect of the humeral head in the glenoid, but because of the damage to these tissues that's occurring, you get pain and inflammation, which we know is a big strength inhibitor. And when you have pain and some limitation of motion stiffness, you're going to have decreased performance. So let's go to the stabilizing of structures here in the shoulder and the pathology that can occur where. And this is a pretty good schematic to have in mind because it gives you a differential diagnosis depending on the geographic location of your pain. Hey, Sydney, I need some help getting this picture off the top here so I can see the whole slide. I want to see up here. There we go. So in the anterolateral aspect of the shoulder, you can get pain secondary to bursitis, subacromial, and subconjoint tendon impingement. Don't forget about that you have the conjoint tendon crosses the subscapularis and attaches to the to the coracoid, and the space underneath there is very tight. And so if you have anything that's causing any type of anterior translation that can occur with labral tears, even small labral tears, or if you have a very tight posterior capsule, so the humeral head just doesn't fit posteriorly whenever you rotate, and it's shoving the head anteriorly, you're going to close off that space where the conjoint tendon is coming up from the arm and it's attaching to the coracoid, and it's draping itself right over this subscapularis. And so the tissue underneath there and the long head of the biceps, the groove is sitting just lateral to where the subscapularis attaches to the humeral head. So as that rotates internally, you're going to bring that prominent part of bone and the biceps tendon underneath the conjoint. And so I'm going to show you a case where we see some very thick chronic bursitis that forms underneath there and can cause anterior pain. Biceps tenosynovitis, we all have seen that a million times. Zone 2 is the area in the bicipital groove, just above the pectoralis tendon. And so the pectoralis, as it crosses the bicipital groove, can cause another area of impingement and incarceration of the biceps and causing chronic biceps tenosynovitis. Slap tears, you can get anterolateral pain because of tension applied to the anterior superior aspect of the shoulder as the labrum moves away from the glenoid and it irritates the anterior structures, and also because of this decentralizing effect that it has on the humeral head, and it can move anteriorly. Certainly, anterior cuff disease, tuberosity, and stress reactions of the greater tuberosity, anterior capsulolabral injury, capsulitis. Those are the things you should be thinking about anteriorly. In the posterior and posterolateral aspect of the shoulder, pain there, rotator cuff pain is very, very often going to be with posterior posterolateral pain. Slap lesions, depending on the position of the arm that you put it in, is going to cause not only anterior pain, but posterior pain too. Tuberosity stress reactions, like I showed you, that those stress reactions can be painful with the marrow edema and the posterior aspect of the greater tuberosity. Glenoid chondrocapsulolabral hypertrophy is going to cause internal impingement and synovitis in the posterior aspect of the shoulder. That's going to hurt back there in the back. Posterior capsular injury and capsulitis once again. Additional considerations to think of, okay? You, think of when you have injuries to the subscapularis, latissimus, teres major. Sometimes these are very difficult things to see on MRI scan, difficult places to discern injury. And unless if you have an experienced radiology tech and radiologist, it's going to be hard for them to get this every time on an MRI scan into clear view for you. But if you have pain in the provocative position of abduction external rotation, you're getting axillary pain. Axillary pain is not pain that you should be getting from rotator cuff or from labrum. Axillary pain is a very unique site of pain. You got to think of atypical things. So think of lat, think of teres major, and I'm going to show you that axillary pain also occurs now with capsular injuries. AC joint problems is another additional consideration. Pain at the AC joint, we all see that with throwers. Glenohumeral chondral wear, that is the great masquerading diagnosis. So that can cause pain with cross-arm adduction, the internal rotation behind the plane of the body, and with the extremes of motion. So if you're having trouble to figure out, looking at all the other structures, you're saying, okay, all these other things look relatively normal. Think, can this person have some chondromalacia that can be causing this? And of course, neurogenic problems is the big differential diagnosis for atypical sites of pain. So capsulolabral injury, we're going to talk about superior labral tears. These are overdiagnosed. If you look at MRI scans and you see a cleft underneath the labrum, you have to match that finding up with what you're seeing on exam, but importantly also what the player's telling you. And the player's going to tell you a very typical story when it comes to superior labral pathology: pain at the extremes of motion, and pain with the extremes of force and acceleration. That's where you're going to see this type of problem causing pain. Pain within the normal arc of motion or not at the extremes of motion is not going to be superior labral type pain. But if the tear has to be relatively big to really cause decentralizing problems in the shoulder, it has to extend anteriorly or posteriorly nearly to the equator on both sides to really be a major cause of pain. So this does occur, but it's been overdiagnosed and overtreated. The anterior inferior capsule, this may tear independent of the labrum, and I'm going to show you this later in the talk, and this is one of the newer things I'm seeing that goes along with that posterior glenoid dysplasia that we were just talking about. It's important to determine the location of the tear and the direction of instability to determine what needs to be treated. And if you can't figure this out, you're going to end up inappropriately treating a lot of different types of labral tears. So you've got to really become comfortable with your examination. Go back and forth between the exam, the player's history, and looking at the MRI scan. And you have to determine the symptomatic function that is being affected. Is it throwing? Is it the lead shoulder in a batter? What phase of throwing or what phase of batting is symptomatic? What position is the joint in with this? So understanding what the function is of your player, when it's occurring, and with what activity, these are all things that at my stage, doing this for 30 years, I need to go back and I need to look. I need to be really in tune with what my player is doing and when they hurt. Generally, if you have a traumatic injury to the capsule or labrum that's causing instability symptoms or pain, usually it requires some sort of surgical repair. But if this is attritional and it's more on a chronic long-standing basis, then the therapy that these guys are going to go through is the mainstay of treatment. So where do you guys do the best for the player, keeping them out of the surgeon's hands? Unfortunately, it's hard to pick up the problems back here because oftentimes players aren't complaining of stuff back here. They really don't start to complain of things until you get here. But if we can get better at figuring out the shoulder at risk before they start to get pain, we can pick it up when they're back here. And so if on their physical exams, if you're noticing total motion arc loss, significant internal rotation deficits that aren't attributed just to bony causes, we can pick up these shoulders that are at risk before they get here, because once they're here, it's only a short time before they get these irreversible changes that then I have to address. Good conservative treatment, obviously you got to take them out of the activity that they're doing, get them out of the inflammatory phase of their problem. Bursal injections and selective injections are still very helpful. Whether you mix corticosteroid with biologics like plasma injections, certainly don't forget the importance of being able to put local anesthetics in, because selective injections can help you figure out, is this an intra-articular problem, extra-articular problem? Is it a biceps tendon sheath problem? Is it a subscapularis bursa problem? And so these selective injections can be very helpful, and they're helpful in treating them too, because I'm going to show you some cases of classic bursitis that still does occur that corticosteroids can help. We talked a little bit about intra-articular injections. If it's going to be an intra-articular injection, I usually like to mix this with a little bit of a biologic, like a plasma injection, to protect the tissues. Capsular stretching is, you've all gotten to be very familiar and comfortable with this, because our players during the course of a season are going to get low-grade inflammation. It's going to limit their capsular excursion, and so it's very important to maintain their motion. Periscapular strengthening, get them a good foundation for their rotator cuff to function well, and then look for the remote causes of pathomechanics. I get back to this picture here. Look at this. This is Clayton Kershaw, and this is the same phase of throwing, and this is a college level kid. Well, from the neck down, this guy, look at what's happening here. I mean, everything is going wrong. He's stepping to the third base side of home plate, so he's opening too soon, probably opening too soon, because he's having trouble with motion of his shoulder. Because he's having trouble with rotation of his shoulder, he's hyperangulating to try to get to what he feels like is his set point to get his velocity. So as he's losing rotation, he's losing velocity, he's hyperangulating to try to get back to his set point to artificially manufacture velocity. He's hyperlordotic. So because of that, he's not able to generate significant power with his push-off leg. And so I think that Nick Conte, Stan Conte, Joe Benge is hopefully going to talk about some of these pathomechanics to get you in trouble. But from my perspective, it goes to with my talk, this lagging slow arm, lagging behind, causes all the pathology that I then have to try to address. And addressing some of these problems surgically is not that easy. So get back to, if rehab fails with regard to this, then they end up with these irreversible sites of damage to the labrum, rotator cuff, biceps tendon, capsulabral injury, and then what we call, the title of this talk, thrower's instability. This is a arthroscopy of the throwing shoulder, taking it into the throwing position. A dynamic arthroscopy is important. I like to take my throwers and put them into the throwing position while I'm scoping them and see what's happening, see how the tissues are responding. So With regard to anterior shoulder pain and plus or minus instability, my surgical things in my armamentarium, I either debride degenerative flaps and fraying, I examine the biceps, check the remaining labral tissue for the ligamentous attachments. So after I debride the flaps, I go back and I look at the labrum, see where the superior middle glenohumeral ligaments are attaching, look at where the steep fibers of the inferior glenohumeral ligament is attaching. Is the labrum detached at those important sites of attachment for my static stabilizers? If the superior labral tear violates the biceps anchor and it extends to about the equator of in the anterior quadrant or down to the equator posteriorly, that's a significant superior labrum tear for me. Just a cleft underneath the biceps means nothing to me. Even a small cleft posterior to the biceps means very little to me. But if you have a tear that involves basically the entire superior hemisphere from equator to equator, or if the biceps anchor is off and you have a posterior labrum tear down to the equator posteriorly, that biceps is unstable. Those patients are often symptomatic, and if they don't get better with training and physical therapy, those are the kinds that need to be fixed. Biceps luxation. This is almost impossible to take care of just with therapy. So if you've damaged the anterior structures near the subscapularis, the high up in the rotator cuff interval, and the biceps has now lost its stability, these problems are painful, and it's very difficult to treat. This was this shoulder with this big flap of tissue. The tissue from the supraspinatus, which is here, and the subscapularis, which is behind this blue cannula, form the stabilizing sling of the bicep. As that gets damaged, that belt loop gets loose, and the bicep starts to slide around. Here's what the MRI scan looks like with this bicep starting to slip up onto the lesser tuberosity. That's pretty painful. That requires, by the way, you can't stabilize that bicep. You have to do a tenodesis in that. So here's that shoulder, and a shoulder like that, I should say. The intra-articular segment of the biceps is diseased. This person had bicipital groove pain. So I know that person had pain that was emanating from the biceps because he had a positive injection test. I numbed up the bicipital groove, pain went away. So I knew that this was causing some of his pain. But not only was that a problem, so once we separated that in preparation to do a tenodesis, we have to go back and take a look at the labrum. He's separated from equator to equator. The entire superior hemisphere is off. Here's the big sling of the superior capsule, superior glenohumeral ligament. The middle glenohumeral ligament is coming here. So his static stabilizing structures have no attachment. And so even though I did the tenodesis, I went ahead and repaired his labrum. This is called a slapodesis. So you take care of the slap lesion with a repair, and you do a tenodesis of the bicep in this one. Here's a normal anatomic variant. This is a cord-like middle glenohumeral ligament coming in and trying to attach to the superior labrum. There's a naturally deficient labrum here. This is a Buford complex, cord-like middle glenohumeral ligament, no significant labrum anteriorly until you get down to the inferior quadrant. So if you have a tear of the labrum here, the cord-like middle glenohumeral ligament has no bony attachment. So this is the kind that causes some anterior instability and anterior pain. So instead of you don't want to repair, this is not the labrum, this is the ligament. If you repaired this down here, this guy's going to lose motion. You have to go right to the site of trauma and detachment, so that gets repaired here. And this tear did extend posteriorly, so we repaired it in the back and in the front. Stay away from the base of the bicep. So we don't like to put any anchors or sutures at the base of the bicep because we want the bicep to have its full excursion. Avoid labrum repairs when you have significant glenohumeral chondromalacia, if there's any evidence of significant capsulitis. So if the capsule itself is inflamed, it's going to be very difficult to get that motion back. or obviously in older patients with coexisting pathology. Look for other sites of pathology that could be causing pain before you commit this person to a labrum repair. So if you're in doubt as to the significance of the labral tear causing pain, look for other sites of problems: subacromial space, AC joint, cuff, again, articular damage, and the bicep. The rotator cuff pathology is a source of pain in a lot of athletes. So I think that one of the reasons why slap repairs got such a bad name is not because the repair wasn't done well, although some of them were done making the shoulder too tight, but it's knowing who to do it on. You know, I think that the indications, knowing who to do what on is as important, if not more important, than actually doing the surgery itself. So if the rotator cuff is what the pain generator is and you repair the labrum, obviously it's going to fail no matter how pretty a labral repair you do. This is a diagnosis, the peel back, that I think set us back. Those of us that are operating on baseball players set us back for a good decade. What this theory was that with external rotation and abduction, you would get a torsion of the bicep, and then this labrum would peel back off the glenoid rim, and this, we were told, was pathologic, and this was what was causing pain. And so the treatment then would be to go ahead and chisel this attachment off and rigidly fix this labrum back onto the glenoid rim so that this couldn't move. It couldn't move with rotation and abduction. Well, what happened was this completely ignored what the function and normal dynamics of the superior labrum is. The superior labrum is mobile. It's supposed to move. It's supposed to roll back depending on position and rotation of the labrum. And so if you stop that normal motion from happening, only bad things are going to happen. So when this would get rigidly perched on there, they'd lose motion and they would increase their internal impingement because this thing was stuck on there. It couldn't roll out of the way with external rotation when they were getting to the top of their motion arc. And so these patients sometimes were not only not better, but they were worse. And so this is a normal adaptation. This is what the supralabrum is supposed to do. So I don't repair this. This is some of the things that I do see, though, in a thrower. These bucket handle tears and complete separations and tears of the labral tissue away from the glenoid. You know, I look for this, and depending on how big this flap is and what it's attached to up in the front, this tells me if I should be just removing this, or if I need to try to do everything I can to save it. And I'm going to show you some reasons why that I've in some players I have to save this, because if I sacrifice this bucket handle segment, if I go up in the front and I follow this in the front, this is the attachment site for the big ligaments up in the front anterior superior quadrant. If I lose this, I've got nothing to stabilize the shoulder anteriorly. Also, if I lose this big segment, I've got this big gap between the entire biceps root and the glenoid. And then so if I try to make up for that and repair that down without this segment here, I've overconstrained the bicep. So this is, I think, was another problem when they would see this big problem here in the labrum, cutting this out and then repairing that down. That was never going to work. So what I try to do now, if there's a big bucket handle flap, I repair that. And this actually, I'm going to show you some pictures. This actually heals very well. So anterior, posterior, and inferior labral tears. The anterior ones are usually associated with instability. The posterior ones also with instability. And if you have an inferior labral segment that's joining a posterior labral tear and an anterior labrum tear, that's also going to be unstable. So the key, though, is in a throwing athlete to repair this with minimal capsular tightening. If you take a normal civilian or a contact athlete like a football player, you don't mind taking bites of capsule along with your labrum. If you've got a throwing athlete that has to have good range of motion, you better repair just the labrum. Otherwise, they're not going to be able to function properly. Now, this is what I've been seeing over the past few years. This is This is looking from top down. I'm looking from the top down. This is the anterior inferior capsule. The anterior band of the inferior glenohumeral ligament is right here. The inferior capsular recess is right here. And this is the tear. Okay, so this diagnosis is not necessarily going to cause gross instability, although I'm going to show you a case of somebody that actually buttonholed and dislocated through that tear. But it's usually the symptoms that they're going to present with is pain in the axilla or anterior aspect of the shoulder after throwing or at the extremes of motion during a throwing motion. Stan wanted me to talk a little bit about suture technique and what we're actually doing inside the shoulder. The top, this picture, and this picture, this is a professional pitcher. This pitcher had a posterior labrum repair done, and this was done with the classic suture anchor, then with suture knots that were through and around the labrum. Over time, after a few years of him going back to pitching, he eroded that posterior labrum, but that suture knot was still, suture stack was still there, caused this area of chondromalacia in the back part of the glenoid. These are irreversible issues that crop up that you can't really change, make up for that. So this is a site of arthritis now in the shoulder, probably as a result of trying to do a good labrum repair. So this is the shoulder after that stuff was taken out and after I cleaned up the posterior labrum. So this is a thrower that had a superior labrum repair done, and in the op note, I read and saw the pictures of a pristine rotator cuff. Well, look at what's happened after this guy went back. That suture stack is now causing a problem and tearing of the rotator cuff because it's embedding itself with external rotation right into the cuff. And don't forget, it's very difficult to fix cuff tissue in a thrower. So because of these findings, we wanted to try to minimize how much suture material we're putting in there. This is what I considered at one point in my career a really beautiful labrum repair with these, there's like a mattress, and I was perching back on there with a meniscoid position on the glenoid with my knots here. But when I started to see pathology in the chondral tissue of the glenoid and the rotator cuff, I went away from doing this and I started to do this. I started to try to hide the suture as much as I could away from the tissues that would get injured by my suture material. And these are other examples. This is a posterior superior labrum repair. This is the biceps tendon, so this is anterior and posterior. This is looking from the top down. This is the posterior inferior labrum, anterior inferior labrum. So I've gone to basically minimizing how much suture the inside of the joint sees. So we developed the knotless approach to these labrum repairs because of this. And our outcomes are very interesting when you look at it. Not only does it, this is global data, okay? So this isn't just my data, this is global data, knotless techniques fixing, this was to be a labrum repair, knotless versus knotted. So a typical labrum repair might take about 53 minutes, knotless 78 minutes. Seems like a little bit long, but this is global data. But interestingly, look at this. The further you get out from the time of surgery, the knotless repair tends to perform better. This is a SANE score, so the higher is better. Wonder why this is starting to deteriorate. It's possibly because of the accumulated damage that that suture material might be doing inside the joint. So now you're starting to get symptoms of rotator cuff problems or abrasive changes of the chondral tissue. That I would surmise that may be a cause of deteriorating scores over time, as yet unproven, but certainly I've definitely seen some irreversible problems that crop up. And once again, OR time is less. This is a picture of doing a labrum repair. I know I'm going pretty long here. I'm going to try to get moving so that I can hopefully take some questions. So this is doing a superior labral repair. I like to try to recreate the meniscoid position of that. And by doing this, in this way. This doesn't rigidly perch this back on there. So with motion of the shoulder, the labrum is still going to be able to roll. It'll still be able to move. It'll heal on there nicely, but it won't be rigidly perched. And so it will still be able to move like a normal superior labrum. I was talking about the bucket handle tears. Those bucket handle tears, the reason I'm showing this slide is because this looks like there's no way this is going to heal if you try to sew that, right? This is completely macerated and shredded. The reason I didn't want to take out this superior labral segment is because it's attached to the middle glenohumeral ligament. I would have nothing to stabilize this thing in the anterosuperior quadrant. So I wanted to save it. And there would have been a big gap underneath here. So I had some hope that this might heal because I could see some vascularity here. So I went ahead and sutured the bucket handle back on and then repaired the labrum anterior and posteriorly. And the person went back and competed in the Olympics the following year in water polo. 2 years later, because of chronic AC joint pain, I went in to do an AC joint resection on this water polo player. And sure enough, I got a chance to look at this. Look how that whole thing healed. This is what I started with, all this chaos, and this whole thing had healed. So this gives me some evidence that those labral bucket handles will heal if you give it a chance. So this was that thrower that I showed you. And then just passing the sutures through. I don't need to belabor that point, but this is another part of a technique that has changed my life with regard to doing labral repairs, because it was impossible for me to get anchors appropriately positioned at the 6 o'clock position of the glenoid until the percutaneous instrumentation came about. So I was able to actually go down and point anchors directly at the bottom of the glenoid and fix the inferior labrum on there without trying to stabilize it by over tightening the anterior inferior and posterior inferior labrum. So this is again another shoulder. This needle is coming in just posterior to the 6 o'clock position. 6 o'clock position would be coming in right here. I'm coming in just posterior to that, and then placing my anchors. And see how the anchor can be directed right at the center of the glenoid rather than tangential coming through my standard portals. So you can expect about an 80% return to the same level of competition in the studies we've done if you don't have significant tearing of the rotator cuff. So if you have labral pathology without significant damage to the rotator cuff cables, you can expect an 80% chance of return. The previous studies that showed 57% success and less didn't separate out the shoulders that had concomitant rotator cuff, bad rotator cuff pathology. You can expect 90% return to the same competitive level after labral repair if the problem you're treating is traumatic instability. So if it's pain and micro instability with throwing, it's going to be about 80%, 90% with traumatic instability. This is what I wanted to get to here, because this is the newest bane of my existence, is these capsular tears. This is the pathology we see with that thrower's dysplasia. Big, thick chondrocapsulabral junction posteriorly, abutting the posterior rotator cuff and humeral head. And with extremes of motion, you're going to get decentralizing humeral head. It's going to shove it anteriorly. So this is the subacromial view. This is the big caked up bursa that forms underneath the anterior acromion, big cloud of bursa. And it extends underneath the conjoint tendon. So this is, we're cleaning out that bursitis. This is the conjoint tendon underneath this veil of tissue way up in the front. And so you can get a improper diagnosis of, quote, biceps tendonitis when actually what it is you have a chronic bursitis that's formed underneath the conjoint tendon sitting on top of the bicipital groove. So it's in the right area, but it's the wrong diagnosis. So we clean out all that bursa underneath the conjoint tendon and the coracoid. Now, part of that problem then at the end stage, whenever you get this Benge effect, when you're hitting that big wedge of tissue, the chondrocapsulabral junction tissue in the back, with after external rotation. It's shoving the humeral head forward, and you can get a weakness and tearing of the capsule. What does that look like? Here's the MRI scan. See this big wedge of tissue here? Take a look at what's happening to the capsule. Ruptured capsule. What does that look like arthroscopically? Looking from the back, we're going to see this big tear in the capsule. Here's the anterior inferior glenohumeral ligament. Here's the inferior capsular recess. We're looking right at muscle. That's the muscle of the subscapularis. So what we do with these, put the scope up high. Now I'm looking from the anterior portal. I'm looking at this rip. I've got my accessory anterior portal here, and I've got my posterior viewing portal still available to me. And then so what I do is I pass suture beginning up high at the humeral head. So Stan, I've got 14 players like this now that I've accumulated over the past 4 years with this diagnosis. And they're all in various stages of return. The ones that are a little over 2 years out, I have, there's about 5 of them, and they're all back to throwing and playing at various stages, either in the minor leagues or actually I have one guy back in the major leagues that just signed on with the White Sox. So just like a shoestring, I crisscross them moving from the humeral head down towards the glenoid. Since I'm not tying knots every single place I go, I can't overbunch the capsule. So as soon as, if I crisscross them like this and just run the stitch, as soon as the tissue contacts each other, it can't over tighten any more than that. So I end up with my 2 sutures near the glenoid labrum. I take those sutures. Again, I don't want to put any knots down here. So then I put those into an anchor, dunk them into bone. And that's the repair. So that's what we started with. That's looking at it from the front, and that's the repair. This was the only study in the literature that was produced before our series, and this was only on 5 players. Excellent results early on in 4 of 5. And we had, at the time that we wrote up our manuscript, 11. I now have 14. So the salient points: posterior chondrocapsulabral hypertrophy with posterior glenoid dysplasia. That increases internal impingement. And with chronic use in that position, you get damage to the rotator cuff, cyst formation, and then a Benge effect where it shoves the humeral head down and forward, and it rips the posterior capsule. Now, so it's hard sometimes without a contrast injection on an MRI scan to see this. What is your tip-off that this might be happening? If you see an MRI scan in a throwing athlete and there is edema in the subscapularis muscle belly, think capsular injury. It's capsular injury until proven otherwise, because isolated subscapularis muscle strain doesn't occur. This occurs because of increased strain because of humeral head instability. This is what that looks like with all that edema in the subscap. This is a non-contrast study, by the way. See that edema in the subscap? This person ended up dislocating and buttonholing right through the tendon. So I'm going to go quickly through the last part. This is a dynamic instability that it has to do with the rotator cuff. Rotator cuff cable tears. We've shown that the rotator cuff cable, that's the dense attachment in the back and in the front of the rotator cuff. That's a dynamic stabilizer of the head. And so partial thickness tears that occur in the rotator cuff are well tolerated unless if you get damage to the cable attachments. That's when you start to get dynamic instability. Here's how the rotator cuff should look on the inside. The anterior cable attachment is right there. The posterior cable attachment is back here. This is looking from front to back now. That's the posterior cable attachment. That's the anterior cable attachment. So partial tears, if it doesn't involve that cord or that cord, is well tolerated. Don't worry about what's happening in the middle. But if you get damage to the actual cable attachment, now you've got problems. That in my hands is the only partial thickness cuff tear that I will repair now. So I'm going to buzz through that. So in summary, when non-op management fails, the goal of surgical treatment is to eliminate the causes of inflammation, restore the anatomy. So if you have anatomy that is not going to be able to tolerate the kind of function that your player has to perform, that has to be fixed. If you do have to fix it, you've got to think about motion and mobility, because if you can do a great repair, but if they can't move the way they need to, they're never going to play again. So thank you very much. I'm sorry for going over time. I hope we have time for questions.
Hey, Neal, we're going to do the questions after the next two presentations.
Okay.
Okay. Thanks, Neal, for that. That was pretty great. Our next speaker is Nick Conte. He's going to be talking about the kinetic chain and scapular dyskinesia. He's a former college and minor league baseball player with the San Francisco Giants. Change slide. His education is a bachelor in kinesiology at St. Mary's College, Fresno State, and earned a BS in athletic training at Chapman University. And he's a doctorate in physical therapy from the University of Wisconsin-Madison. Advanced training in dry needling, A-stem, cupping, performance, mobilization, postural restoration, strength and conditioning, and functional movement. He's the ATC for the Dodgers for at the major league level for 2 seasons. He's a rehab coordinator and minor league medical coordinator for the Dodgers in 2014 and 2015. Private practice for the last 4 years, and has been doing research on basically movement patterns and how to improve them in baseball players for integration of lower extremity, upper extremity, and all the hitting and throwing motions. And he's the co-owner of Conte Sports Performance Therapy. He lives in Arizona with his son and my grandson, Michael Anthony. So we're pretty proud of him on that. I just want to do a little prelude to this. When Nick started his clinic in Phoenix, I came down to help him, supposedly to help him. And he showed me some things that I had not seen before in regards to scapular stabilization, stuff that I wish I knew 15 years ago. And he's going to share that with you now.
So I'm sharing my screen, right?
Yes.
Okay. All right. All right, so about 1.5 years ago, we started Conte Sport Performance Therapy in Scottsdale, Arizona. We started this clinic with the philosophy of having a program that is much like the medical program in any professional level training room. So athletic trainers, physical therapists, and strength coaches all working together with all the patients. So the whole roster of patients is treated by the whole staff based on everybody's expertise. To do that, we realized that we needed to have a philosophy, a general philosophy that we all had trained on together, we'd all implemented, and an understanding of how it worked in our programming, so that as we all worked with each individual athlete or patient, we could transfer that over. So what I'm going to talk today about is clinical movement-based progressive interventions for retraining the scapula and the kinetic chain. So this is kind of what we put together is a movement system for retraining the kinetic chain. And that chain, that system is based in reciprocation. So if you've studied postural restoration, PRI, you've heard reciprocation quite a bit. The idea of getting from one side of the body to the other. And when we're talking about scapular dyskinesis or scapular kinesis, we're really talking about that retraction and protraction, or getting from one side to the other, and the same thing in the pelvis. So we're reciprocating motion from one side to the other side of the body. So you can't talk about scapular kinesis without talking about the entire chain, because if the shoulder blade is not working on a base that is also reciprocating, then we're going to have torque that is not properly transferred up the chain, or the foundation for the shoulder blade, the rib cage, or the obliques are not going to put the shoulder blade in the position that it's able to reciprocate properly, regardless of how you train it locally. So when you look into baseball, that's exactly what we're looking at, is backside load and frontside transfer. It's really easy to see, especially in the pelvis. We get into the backside, we transfer into the front side. And ideally, we're doing this in the pelvis and the hips and not in the low back. See a lot of people rotate in the low back, especially in the follow through. And then when we look at the shoulder blades, we want the scapula to be protracting and starting this rotation around the thoracic spine, and not the lumbar spine, with that lumbar rotation being kind of the last piece of the puzzle, with some of the best hitters getting very little lumbar rotation whatsoever. So when we're looking at any movement, we're just looking at different forces and with different directions and the kind of torque that they're creating around a joint. So in this situation, looking at the pelvis, we're getting backside drive from the back glute, and a front side pullback from the adductor and hamstring. And this is creating rotational torque as the pelvis orients itself over that front leg. So the pelvis is rotating over, and the acetabulum over the relatively fixed femur, causing femoral acetabular internal rotation as the pelvis internally orients right there. So same thing with when we talk about the upper body, we're looking at retraction and then internally orientation through protraction. And then how we do that is about looking at the whole chain. So how do all these pieces fit together? I want to touch on what muscles we feel are that proper motion pattern and proper chain activation. But my real goal today is to go over the progression, the exercise progression that we're using to retrain these patterns, to retrain the scapula, to retrain this kinetic chain to work properly, and not miss any steps along the way, so that we know that there's no chink in the chain. Let's see. The interorientation and extension and drive is a huge part of this. When we talk about the chains, if you have studied PRI, this is a lot like the AIC and BC chains, just for those of you who have studied that stuff. And really we want to inhibit like PEC type chains. So just a tidbit for the PRI people who kind of know those chains. But what is important is identifying what you want to activate, and then how they feed into each other, how these muscles feed up and down the chain. When we're able to coach the chain in locally, that's excellent. But a lot of times, local intervention is enough. We're able to protract the scapula, but if the lower half is not in the proper position, or the lower half has already created the improper torque, like rotation around a joint, then we're stuck in a position where now the torque is not even going through the shoulder blade like we wanted to. Now the elbow is dragging, and we have no chance for protraction of the shoulder blade. These chains we've simplified a ton because we think that athletes need to buy into what we're doing. So when we're teaching athletes how to move, we're teaching them this philosophy of movement and reciprocation from one side of the body to the other. We're teaching the shoulder blades and the scapula how to reciprocate. We're teaching the pelvis how to reciprocate, and how the obliques and abdomen does the same, transferring those forces. And if we throw too much information in there, a lot of times we can't get the buy-in, people kind of give up, or we won't be able to have reproducibility. So it's really important that we take these ideas and they can carry them over to different tasks, different exercises, and then eventually be able to bring them onto the baseball field. One of the greatest things that I've seen in terms of looking at these chains is when you're talking to a coach and you look at it in terms of what we are coaching, they typically use terms like load the backside, get in the backside, transfer force into the front. What our training allows people to do is have specific ways, specific muscles, specific techniques, and specific exercises to accomplish this goal, to make it happen, and then ways to fix it when they feel like it's a little bit off. So I'm, again, not going to go over these chains much, except that I want to talk about which ones we are trying to activate when we're coaching our exercises. So for example, when we have a right-handed pitcher in the acceleration phase, just like in this picture, our right arm is throwing, so our right serratus is trying to bring the shoulder blade through. We're trying to do that through protraction and not early upward rotation, not elevation, and not anterior tilt. So we want to avoid upper trap dominance, which we see a lot, upper trap overactivity, pec minor overactivity, and then the bicep tends to play a large role when it's overactive in trying to stabilize the shoulder and bring the shoulder blade through, especially when we have some pathology going on. So the right serratus is directing our shoulder blade, right external oblique, and then onto the other side, the left internal oblique, left adductor and hamstring are bringing our pelvis in, and our left down to the foot, the left peroneals and arch support is able to keep that foot internally oriented and not roll out for as long as possible. So the pitchers that you see who lose their front side, a lot like the picture that Dr. Elattrache had with the lagging arm, when I see the lead leg stepping off to the third base side, I'm thinking, one, that's obviously the wrong direction, but this player has rotational force going towards third base when he needs to be pulling in towards the pelvis. That front leg needs to have landed, got a good support on the ground, and then been able to pull himself through the pelvis, internally orienting the pelvis over that front side. And that's how you're going to get to transfer your backside drive towards home plate. The driving force, of course, being that backside glute, the left lat, right glute med, anterior portion, and then down to the foot. But we don't want quadricep dominance, and we don't want left TFL. And I'm gonna talk about how we go through exercises to accomplish these goals, and that's really kind of the point of what I'm trying to accomplish here. Again, these are much like PRI chains, so they might look familiar to you if you've done some studying on the PRI stuff. So looking at pitcher throwing, basically what we would do is break down the chain from top to bottom or bottom to top, depending on kind of where you think pathology lies. I typically look at something that's going right and then work my way up. So for me, his bottom half is going great. He gets in the back side. He lands on the front side and pulls through well with his hamstring and adductor and doesn't rotate off. And then when I look up the chain, I see that his shoulder blade really doesn't come through like I'd want. It doesn't protract. And I wonder why that is. So those are kind of the thought processes when I'm thinking about those lines of torque. So when we go into coaching, what we want to do is first break down the specific pieces. So we do these three things in isolation: scapular reciprocation, pelvic reciprocation, and core and abdomen reciprocation can all be done kind of in isolation, and then we bring them all together and integrate them and go to athletic performance and training in sports. So I'm going to go through a bunch of exercises, and these typically are done progressively in our clinic. We try to make sure that they don't move forward. So sometimes we'll spend a lot of time on any one given exercise, making sure that we are activating the proper muscles. We have the baseline strength and stability, the baseline range of motion, and basically the concept down, so that if we go to more complex exercises that are integrating all of these pieces, then we're able to cue some of these muscular changes that we've already coached. So it's nothing new when we say, you have to bring your shoulder blade through, get your ribs down, or pull into your front side. We've explained what all those things mean. So we typically start with the shoulder blades, because typically our patients are patients with scapular dyskinesia or some kind of shoulder pathology. And although you could start at the pelvis, and especially for patients who are maybe or post-surgical, that's a great place to start. But it makes a lot of sense to the athlete to start at the shoulders if you're seeing them for the shoulders. This wall position is great because if they can put their hands on the wall, we already know that they can at least elevate to 90 degrees without pain. So we can start here. It also gives us a good chance to see what their strategy is going to be. If you just give the simple cue of put your hands on the wall, you get a ton of feedback on if they're going to be upper trap dominant, if their shoulder blades are going to move like we want them to in protraction, or if they're going to upwardly elevate or rotate. So from here, we do a lot of manual and verbal cueing to basically say, push into the wall, pull your sternum away from the wall, bring your shoulder blades forward. What we're trying to do is get the shoulder blades into full protraction. And so the player can, one, activate their serratus, but more importantly, feel what that muscle means. A lot of people come in and just don't understand how the shoulder blade gets forward, how it's supposed to come forward and protract, and they can't proprioceptively appreciate where their shoulder blades are in space, that the shoulder blades can dissociate from the humerus and move on their own, and how much range of motion the shoulder blades really do have. One disadvantage of us doing a lot of isolated exercises when we pinch the shoulder blades back is that we're training the shoulder blades to work in one static position. So we spend a lot of time, once we know that we have the proper mobility and stability in the glenohumeral joint, is teaching the scapulothoracic joint how to move through the full range of motion, because we spent so much time locking the shoulder blades in, keeping them in this retracted position when they really need to work functionally through a full range of motion. After that, of course, a lot of people just don't have the strength in the serratus because they haven't activated it, especially through their full range. So we'll just use this position as a holding position to exercise the muscle, strengthen it, get it more endurance, and then continue to try to not activate our upper traps, our pecs, and then we can go from there to W exercises. So this one is just a progression off of the wall holds, but now we're using active range of motion through the shoulder blade, keeping the serratus on the whole time. So if you watch his back position, it's still kyphotic and slightly exaggerated. And one reason for that is we want the player to feel this serratus activation almost into an extreme, so that when he takes his arm off of the wall in retraction and brings it back in protraction, he can tell immediately if that serratus has been activated the whole time. We want it to work both concentrically and eccentrically to guide the shoulder blade back along the rib cage and then forward without upper trap turning on and pec turning on. And you can really tell very easily in this position when you watch the upper traps and the movement of the shoulder blade if we're going to get that anterior tilt upward, that elevation or that upward rotation. So this position is great again for proprioceptive feedback of where is the shoulder blade. We can start to train the lower trap to work instead of the upper trap, and we'll spend a lot of time right here just trying to get this feeling where a lot of times at first people are very upper trap dominant and they are just pulling that shoulder blade back with their upper and middle traps. The lower traps are if anything, close to inactive. And then that serratus will turn off that whole time. So it's a pin back quickly, and then they bring it forward and have to reactivate the serratus at end range when we want them both to work in concert through this full range of motion. Let's see. So once we do that, we've got off of closed kinetic chain. And I did want to mention we start in closed kinetic chain because it's a good position to, one, lock in the humerus. The humerus is in a fixed position, so we can just move the shoulder blades without confusion on if we're just thinking about where the arm is going. A lot of people, when you tell them to move their shoulder blade, will move their entire arm because they haven't figured out the dissociation between the two. But also in closed kinetic chain, we find that we get better serratus activation, better upper trap inhibition, better lower trap activation, that all the muscles that we want to accomplish. So now, after we've been able to accomplish that in closed kinetic chain, our open kinetic chain bow and arrow exercise is a great one to, again, go through active range of motion of the shoulder blade. But we also have feedback from the wall, so we can work on a couple other things here too. One, we don't want to promote early rotation of the thoracic spine. So we want the shoulder blade to start moving before the thoracic rotation occurs. So we're able to have that feedback from the wall that our back stays on the wall even though our shoulder blade is coming off in protraction. We can also look at the pelvis. The pelvis here is in posterior tilt, just like you would coach transverse abdominis recruitment. And why we're doing that is, one, if we have someone that is extremely lordotic, this is an easy way to put them into more of a neutral position. But we also want to train external obliques here. So the external obliques attaching to the rib cage and down into the pelvis if they're working on a fixed rib cage, pull the pelvis into posterior tilt and give the serratus a great base to work off with a more stable rib cage. So here's a great position to feel the back and work on that pelvic tilt and start to coach what that external oblique feels like in holding the rib cage in place. And then finally breathing. We are able to breathe in this position, feel the back expand against the wall, knowing that we're not flaring our ribs forward, that we're breathing in all angles of the rib cage, expanding in all directions, and not breathing it, not upper trap breathing, because we don't want to start to feed that system where the upper traps are turning on right away before we even get started. So typically after that, we can get off the wall, use our own proprioceptive feedback. So here our fingers are on the wall and we're fighting to get our palm towards the wall. So protracting the scapula as we push forward. Now we have to use the obliques to keep our pelvis, to keep our trunk perpendicular to the wall. So if you lose those obliques, you'll either lean forward, so forward tilt, or flex your upper body forward, or you will rotate. So this is a good time to give them a little feedback on what it feels like to be able to activate this shoulder blade properly and have a good base for the obliques. We can do some breathing here again, and this is a great place to feel the serratus. If you're doing this properly, pushing your hand towards the wall, you should try this one. This one really helps you appreciate that serratus and what it feels like to turn it on and use it. Getting better as we've done these, we're getting better at full range of motion from the shoulder blade. So this is another great way to try to gain that full motion of the shoulder blade forward without too much compensation. So at this point, we feel like we've done a pretty good job of starting to coach the scapula. We've also done, of course, basic exercises and strengthening of all these muscles that we're trying to activate along with this. But these are our base exercises to train that movement pattern. So as we're training this at the exact same time, we're able to start to work on the pelvis and train that same kind of reciprocal motion that we were training in the shoulder blades. So the shoulder blades are moving from retraction to protraction. Our pelvis works in a similar way that, of course, is attached. So we're going to get basically the same as protraction and retraction of the shoulder blades, except our pelvis is going to be rotating. So we start off much like we started at the wall serratus, in a position that is pretty simple to get into, that is not too hard to hold, and in this situation, as much gravity eliminated as we can make it, so that we can try to turn off pretty much everything, turn off all muscles, and activate only the hamstrings, only the adductors, and start with that activation pattern. Make sure that I'm getting okay. So we want hamstrings and adductors to fire here without quad dominance. So the very first thing that we're doing is teaching people hamstrings only, adductors only, no quads. Learn how to just fire those, and then appreciate how the hamstring is able to manipulate the pelvis and tilt it up into the air, rolling it up, not compensating with glute activation or back activation, and appreciating just those muscles and how they turn on. After that, what we want to be able to do is shift into one side or the other. So here we're going to shift into the left side by pulling back on the hamstring and adductor. With the fixed foot on the wall, the adductor is able to pull that knee down and basically pull it by pulling onto the pelvis. And that's what we mean when we're saying get into the hip, get into the left hip, get into the right hip. Is that side, the left hip, being the left adductor, is pulling down into that hip. So this is a good place, again, to learn how to get into the hip properly without compensating by having back rotation. We want the hamstring and adductor to pull down into that side. And then we'll do both sides of this just to feel that reciprocal motion back and forth. Once we're done with that, we try to get off the wall pretty quickly into a more functional position. So we get into this kneeling position next. The front foot is doing that exact same pattern. So we're trying to pull into that front foot from the hamstring and adductors, effectively pulling on our pelvis and orienting it towards that side. So on the right foot here, if our right foot's down and we're pulling back on that hip through our hamstring and adductors, it really should orient our pelvis towards that hip, towards the right side, for creating relative femoral acetabular internal rotation. So if you think about like your zipper line on pants, and you pulled in, that zipper line would orient towards that up leg. On the back leg, we're just trying to feed this pattern. So right side is pulling in hamstring adductor, back side is glute firing and trying to fire that, push the glute forward, and then we can coach the obliques at this time. We also add the shoulder uppercut just to kind of work on this circular protraction and feel how the chain is kind of fed when the serratus activates properly, and we're getting our lower half working through the chain. We're getting reciprocation in our lower half. The chain activates much simpler, and this is a good like kind of aha moment. Okay, I can feel how when I protract my scapula and kind of elevate, I can feel my right adductor, my front leg adductor pulling back with it. They work together through the obliques. The obliques are a tough thing to understand. So a lot of times for our patients. So we're putting our lower half in the same position. The front side's pulling back and the right side's firing forward, just like we would if we were just like if we were throwing or hitting and trying to push into that front side. Here we're trying to encourage activation of the obliques. So we like this rope exercise because you have to reach up, and it gives a nice rounded path for the shoulder blade to work. But also when we pull down, we can coach the oblique on this side to activate as we want it to. So on the left side here, we're trying to activate external oblique, in which case it's working on the pelvis to posteriorly tilt and staying isometric on the rib cage. The idea here is that if you're watching his left flank and his back, that it's not going forward or rotating forward. And on the right side, we want the opposite. We want internal obliques to be rotating forward. So that's what we're trying to coach and trying to teach that feeling of, okay, what are my abs supposed to be doing in these positions? And then we bring them together. So we've coached the reciprocation of the shoulder blades. We've coached the reciprocation of the pelvis. And we like this bow and arrow lunge position because we can now do both and go back and forth. So obviously reciprocation isn't just one-sided. We have to go from one side to another to another. So we're able to feel getting into the left hip here with the left adductor drawback, and then following that up with the opposite. Right adductor is drawing back and the opposite glute is firing while our serratus is protracting the shoulder blade. We can easily coach the obliques in this position. So which obliques are supposed to be contracting. And this is a great exercise for that. But it definitely is a moment where we can feel how it switches from side to side, which is something that we've done a little bit previously. But this is the first time that it's built into the exercise. When we talked earlier, that closed kinetic chain position is a really great position to feel serratus activation, but also when you're doing it in a position where you have to stabilize, it's also a great position to activate the abdominals the way we want to. So typically we'll start with this exercise, bear crawl type position, and on the left video you're seeing reciprocation of the pelvis in and out. On the right side, you're seeing that, and now we're lifting our arm, so we're having to use the downside serratus to really protract and really stay stable. On the same side, that downside, our external oblique is activating, and then on the pelvic side, we're pulling into that opposite side. So just watching the video on the right, serratus activation on the right there, and then left adductor is pulling in, and we have to transfer that through the obliques. Again, the closed kinetic chain really helps us activate the patterns that we want, where our tendency is here to activate serratus and lower trap and inhibit upper trap. And then we try to bring this into a more functional position, and we do a lot of bear crawling because we were able to now feel the pelvic reciprocation and really full body reciprocation as we move. Plus, now we're moving the shoulder blade, and it's having to stabilize as it's active, and we're keeping good congruency of that shoulder blade on the rib cage, good stability of the shoulder blade. and a good angle of force through the shoulder blade too. Whereas if those shoulder blades were pinned on his back instead of protracted slightly, think about the shear force that would be going through the glenohumeral joint just based on the angle of that shoulder blade. The more functional we can get with this, the more people buy into what we're trying to do. But also, as we go forward in functionality, we need to be able to apply this without losing all of our concepts. So the running drills are a great way to do this. Everyone's done running drills, but if you look at the upper half, it's just like that W we were talking about earlier, or the wall hold, that we were talking about earlier. Our serratus is in a nice activated position. Shoulder blades are forward. And as he reaches down to start this drive, his shoulders and scapula elevate, and they elevate in a nice rotational way in a more sagittal plane instead of frontal plane, suggesting that serratus is helping them roll up and forward. And at the same time, we're able to work on our bottom side, our lower half reciprocation patterns, right glutes firing, and we can pull in on the left adductor. And then we just try to make that a little more functional. So we do a lot of the sled work. Serratus is still activated, and now we're trying to get our glutes to fire. And another way to do it too, same kind of idea. Serratus is activated, glutes are firing, we're reciprocating our lower half. Just ways of promoting mobility and strength through the shoulder blades, and then of course the glenohumeral joint as well. So then we got to bring it to power, and the one arm landmine is a way that we've been able to do that in the past. Looks like we're not playing here. The one arm landmine allows us to generate force from the lower half, push through the upper half, but because of the angle of the landmine going forward and up, we're able to guide the shoulder blade forward and around instead of straight up. So we're trying to get protraction and elevation instead of forward tilt and upward rotation, which a lot of times you'll see. So you'll see this when you ask someone to do a press at first, they just go straight up with that shoulder blade going straight up. Here we can work on the shoulder blade going forward and around. Turkish get-ups are a great exercise for the obliques because we're getting that stability that we want, and we're getting the right activation pattern. So in this case, we're going right glute and left adductor, just like all the other exercises. But when we talk about the obliques, we have right serratus, right external oblique, and left internal oblique. It's just continuing the same patterning. The Neal to step up press is great because we go from one side to the other. So here he's in the right hip. Now he's in the left hip. The idea is that adductor and hamstring are pulling into that hip, and then the glute is ready to fire. So he's pulled into the right hip there, and then the glute fires on the right, and then the same thing happens when he steps up with the left foot onto the box. Right glute's about to fire, left glute fires, and then we can add a little uppercut, kettlebells, or whatever we want to do so that we can transfer that force up the chain. And because if we're activating the chain properly, that shoulder blade should come through as we're trying to get it to. Plus, of course, we're doing all those other exercises that we had done previously to continue to coach proper protraction of that shoulder blade. Integrating into more and more sport specific and power generation. These are the same patterns as we had done previously, loading the back hip. So he's pulling into his right hip and then glute explodes on the right. Same thing here, getting it more and more like throwing. So loading the back side, transferring and pulling through on the front side. So that front side hamstring and adductor is pulling that pelvis. So watching his pelvis here, you can see how that hamstring and adductor will pull the pelvis and internally orient it, causing right side femoral acetabular internal rotation. So pulling the pelvis and acetabulum over that fixed femur on the front is what pulls that pelvis around without having to use rotation in the low back to direct that force from the backside glute. When we go up the chain, we're working on our obliques, but most importantly, we're watching the shoulder blade and how it comes through. We want this shoulder blade to come forward and around the rib cage. And if our obliques are doing what they should, and we don't have any other compensations, then usually we can accomplish this by this stage pretty regularly. We're just looking at rhythm here and kind of that plyometric strength. Same kind of thing from side to side, feeling the shift, left to right, That bent knee front side is hamstring and adductor, and the back side is glute. And we're still trying to get the shoulder blade to come forward and around instead of straight up. So we're thinking more circular with the shoulder blade in the sagittal type plane than we are thinking in the frontal plane straight up and down when that ball comes over the top. And then we have to bring it back to baseball. So hopefully at this point we've coached enough on lower half and upper half where the player's able to feel what we've been trying to coach in the weight room, in the clinic, and they're able to now implement it with greater and greater force in a position that they've already done a million times, hopefully now with a new sense of what they're trying to accomplish. If we're working with pitching coaches, it's a great time to educate them on what we're trying to work on in terms of this backside drive and pulling through the front side. And if you see these guys, they both have pretty good front side control because that front foot gets down and they pull through as opposed to rotating and falling off. Just a quick touch on some of the supplemental treatments, especially early on. Some of the manual therapy that you can do for supplementing these exercises can be really huge. If we've had a lot of upper trap type dominance, pec and biceps, usually we'll have a lot of trigger points, soft tissue and fascial adhesions in those areas. Plus, when we're trying to work through the shoulder range of motion, especially early with those shoulder blades, with the hands on the wall and shoulder blades protracting, we get a lot of reports of intrascapular type tightness, and that goes away pretty fast. But at first, these shoulder blades just are not used to using their full range of motion. So anything we can do in terms of stretching or MUT or just soft tissue to allow those shoulder blades to come forward without restrictions is a huge supplement. On our Instagram, I'm going to post, so I'd love to talk a little bit more about this. Hopefully I didn't go too fast through some of the chain topics. I really wanted to show the exercises, so I hope that came through like I wanted it to, but I'd love to talk more on Instagram. If you guys don't get a chance to ask a question today, please feel free. I'm going to post a scapular dyskinesia post today, and we can just comment on that. And then a quick thank you to Nancy Flynn and Stan Conte for putting this together. They've done a ton of work, really selflessly, just to spread knowledge. I feel like it's been a great opportunity for lots of people to talk and get together, and we have all this time to better ourselves. Hopefully it's been advantageous for everybody, but they put a lot of work into this, so thank you for that.
Thanks, Nick. That was great. Your mother's very proud of you. Our next speaker is Joe Benge. Everybody knows him as the head trainer for the Tampa Bay Rays. His education is from Loyola University with a BS in biology, master's degree in kinesiology from Fresno Pacific. He 9 seasons in the Rays organization, including 6 as a minor league coordinator. We look at his resume. He's pretty just done everything from the minor leagues to the major leagues in the organization. He was named the 2005 Minor League Athletic Trainer of the Year by PBATS and served as the athletic trainer for the World Team in the Futures Game in San Diego in 2016. He spent 10 seasons in the Baltimore Orioles. And if you want to know what the Baltimore Orioles system does, this is Joe 10 years ago. Man, that must have been a tough ride of 10 years in there because he came out looking a lot different. He's done winter ball in Dominican 2001, 2002, and 2002 to 2003, as well as Honolulu when they had those teams over there in 2007. He's entering his 3rd season as the Major League Athletic Trainer with the Tampa Bay, and this is his daughter, Isla, who's age 9. Joe.
Hey, Stan. All righty. Let's see here. Sure. Boom, boom. All righty. Good?
Good.
Awesome, awesome. All right. Well, thank you for the introduction. I appreciate it. Yeah. I used to have a lot more hair, and also I had puka shells in that baseball card. Not proud of it, but life goes on from 2001. So appreciate the opportunity to be here. You know, in this, you know, we do so much times. We talk about the thrower. And for those of us in the athletic training room, those of us in the clinics, it doesn't matter the level. It doesn't really matter anything, we deal so much with the thrower, but the front side of the hitter is something that, you know, I'd be lying if I said I was in the dugout and consistently thought of that. Consistently a lot of, here comes this swing, here comes that swing, not unless we're dealing with the front side. So when I say functional shoulder instability, I just want to do my best to kind of explore that. There's not a ton of research. We know that. Stan and I kind of talked about that at length. And just what was out there also a lot of times did incorporate dominant shoulder from a thrower standpoint as well as anterior. So we're going to try and touch on kind of everything aside just the posterior aspect. So again, it's the little things over and over. You can see this is Kevin Kiermaier on both sides, left and right. Keep in mind, he's a lefty swinger and a righty thrower. So he kind of has that little bit of that odd profile, but take a look on the left at the right arm. Abduction, flexion, external rotation. Think of the micro trauma. We know he's known for his glove, but then take a look at the right. Think about if he was your traditional profile, righty thrower, righty swinger, look at the impact of the shoulder on the wall. You know, those of us who've been on there, we always have these reckless abandon type players. Think of the traumatic episode that could have occurred here, the chance for us to have to hit the pause button or for him to come in the dugout and just in general say, I can't go. How are we going to manage that? It's not the throwing shoulder, but it doesn't mean that the treatment necessarily has to be any different, but what we're trying to train for is. So without spending too much time here, just looking at the general anatomy, just trying to appreciate everything going on here. Appreciate, you know, the head of the humerus, the size of the glenoid, what we're asking the labrum to do, the rotator cuff, what we're asking that to do, the capsule ligamentous structures in general, and then getting to what Nick was talking about with the dyskinesia. I think one of the biggest things that sets me off is the term low-hanging fruit. I don't know necessarily, oh, the rotator cuff is weak, that's the low-hanging fruit we should go for. Probably not if the rest of the branch is rotten on the tree. If that's the dyskinesia, if that's the entire chain you need to work ground up, because as we're going to explore a little bit with hitters later, you have to think of it in some ways as a pitcher. From that strong foundation, ground up, what the EMG studies have shown, hamstring, hips, glutes, erector, up and through positioning of the bat, what we're asking this tremendously mobile joint to hang on to and to do, and to think of the posterior stresses as the posterior deltoid is really yanking you onto the backside. And even on the front side, think of those wild helicopter, you know, David Ortiz, think of the Fred McGriffs, you know, obviously those are two lefties there, but think of those wild front side. And if they can't be normal, baseball, softball, it doesn't matter, male, female, they can't be normal on the anterior aspect either. We still have to address that. So again, how unstable is the shoulder? We know it has the greatest amount of motion in any joint in the human body. We have the highest mobility, the less stability. But when we obviously think of the thrower, we're getting into that typical cock position. You know, some people have a high profile, some may be in this more lower close pack position that, you know, we feel may be a little more beneficial. But everything there, when you think of a position player chasing a pitch, hit and run, casting the bat, outer third, poor pitch recognition, just what happens at the plate, the ranges of motion that they're working through and what that's doing on the back of the shoulder, it's more than we probably appreciate. And keeping in mind that no single structure provides sole stability to the shoulder. We have to, again, treat everything. I don't believe there's one thing that you address. I don't believe you grab one piece of fruit and say, we did it. You better address everything or you might be heading down the pathway of failure. And if you do reach failure, it's a lot easier to swallow that failure when you know that you've done everything else along the way. Without hammering too much, this group obviously is fully aware of the musculature. It provides a dynamic stabilization. When you think hitter's shoulder, when you think the dynamic stabilization, and you're thinking the posterior forces, or you're thinking what that posterior deltoid's doing, and what we'll get to on the backside and the forces of 500 plus pounds that Dr. Dugas wrote about, and you know, I had read about, which I thought was pretty interesting. The dynamic stabilization is in multiple planes, thinking again, like we had just spoken about. So how do you prepare the shoulder? How do you appreciate the shoulder when we're not sure? It could be, everything could be like a snowflake. Everything is going to be unique in how it's swinging from time to time. And we'll talk a little bit more about that. Understanding that if it performs multiple functions strictly during shoulder exercises, what is it doing functionally? And then talking about even things like force coupling, the rotator cuff force coupling. As the rotator cuff is pulling in towards the glenoid, the deltoid wants to abduct so you can get a superior translation or, you know, a orientation, how you marry those together. And so it begins when you talk about the position player, the functionality. Take a look here. I know our rehab coordinator, Joel, is out there. This, you know, he lived this one. Take a look at the dive back to first. I know Dr. Elattrache was alluding to this. We've all lived this, but take a look. There it is, reaching for the bag. Perfect, right? Well, watch again. It's his left shoulder. Front shoulder hitting. Watch it as it goes into that forceful internal rotation and gets stuck under his body. Now you're thinking like a football lineman. Now you're thinking of that posterior force, that posterior translation. Ron was the head athletic trainer at the time this happened. And if you get on YouTube and actually watch it, you can watch, he's able to get up off the field. He walks to the dugout and then collapses. In discomfort, Ron has to walk off the field with him and through the dugout, holding his left shoulder in place. So it's simple like this. It happens that quickly. We all would have looked at the right shoulder, but the left shoulder was the one that was affected. So again, what is battered shoulder? We're going to get into that. We know it's, in the papers that have been written, the posterior instability due to the repetitive swings, especially with missed balls, but really look under bat lag. If you follow the bat lag down between drive and bat acceleration, really look at the front shoulder. Now this one ends up being a center cut pitch. If you move over one, you can really see that adduction angle isn't really outer third. Obviously, it's a great picture. And for us to appreciate that, because we know that the batting motion is similar to the pitching motion. If you think of the kinetic chain that transfers that large amount of energy from the base, from the legs, through the trunk to the upper extremity to generate bat speed, look at that center cut and look at what the left shoulder is doing. Now envision increasing that adduction angle, because you have to remember from a posterior force, flexion, internal rotation, adduction. So what is the adduction angle? How stressful is it? And you can see through this exactly, how stressful it could potentially be, even with what looks to be a very routine swing. So like we talked about, it's posterior instability. And are we truly appreciating the loads? Again, an EMG study performed in 1993, which I thought was really interesting. And the EMG studies actually go back into the 60s. And they've obviously gotten better. And where we are today is obviously 10 times better than where we were. But these are translated into rotational velocities. We start thinking about the kinetic energy, the stored energy, the counter force. If there's no offset counter force, what does that do? As the bat rotates around the front of the body, the large posteriorly oriented forces have a chance to surpass the soft tissue that's there to guard it. So as we move down, we know a missed outside pitch is considered the predominant predisposed mechanism. There we go, the increased adduction angle. That's that outer third. That's really what they were talking about through the papers. No offset counterforce. If there is no force generated, no energy generated through the bat to the ball, and that ball that absorbs that heat as it comes off, and you drive that, what you're getting into is what the EMGs have shown. So if you're saying 500 plus pounds concentrated on the posterior of the shoulder, the muscles through the EMG, when they studied hamstrings, up glutes, erector, they found, the tricep, the teres, those are working for bat in space. Those are what's going to drive to the ball. We know there's stability. We know it's working towards stability. But that being said, if it's working towards stability, is it doing the best it can in, when it's working towards actually bat in space to drive to the ball? Is it doing the best it can in stability? I don't know if we have the answer. I don't know if anybody has the answer. And I don't know if even doing all the EMG studies in the world could. But that, when I think of batter shoulder, is where I kind of float to, which is, we know the posterior forces, like Dr. Elattrache talked about. We know about the anterior. And from there, we talk about the scapula. What have we done to give it the best chance for success? But understanding that if the muscles aren't given the best chance to stabilize because they're driving to the ball, if they're swinging and missing, and they are increasing adduction angle, there could be a recipe for disaster. And we've done our best along the way. And all we can do is take them into the athletic training room and help them in the best way possible by looking at the total product. So again, touching on that 1993 study, we have to, to an extent, pitching isn't more intricate than hitting, and hitting isn't more intricate than pitching. We can break it down into phases. The wind up, the pre-swing, the swing, and the follow-through. We probably, as an industry, when we think, because none of us on here claim to be hitting gurus, but we think of phase 3, phase 4. You think of the swing. You think of where they get to as they're coming through. That's what we end up watching for. The load, you're going to watch for. And as you're rehabbing these, be it post-operative, non-operative, conservative management, you're watching through the wind up, the pre-swing, that load. But when we think of what we're really going for, it's that swing. So here we go as they're coming through, and that bat is working perpendicular to parallel to ball contact and back through. Is everything we're seeing pain-free? Is it mechanically sound? Those we can only answer once you work with the athlete. But I know Stan and I had an interesting talk the other day, talking about how, he's had experiences. I know, we all have here with the Rays, of taking somebody through a rehab and realizing that they just aren't where they need to be. You need to sometimes pull them out, whether that leads to surgery, whether that means you need to address something else, whether it's a confidence issue because they're stepping in the bucket because what they don't want to do is end up having that load. So they're finding a way to basically just work rotational instead of driving to the ball. What does it all mean for rehab? It means the program needs to be complete. We can't just nitpick the areas. I think, I've been in the game 20 years and I've seen this grow. I was having a discussion earlier today with Brian Ebel, head athletic trainer for the Orioles, and we were talking about, a Hall of Famer he worked with. Actually, when I was an intern, I was fortunate enough to be a PBATS intern with the Orioles back in 1999, because I'm old. And they were working on the scapula back then and talking about what the scapula did, because this player would release their top hand and played for over 20 years. And so by the time he had become an Oriole, he was having the anterior shoulder discomfort. But it goes back to what the programs were then and what they've become now, what we didn't know then, what some believed in, and what we know now. If we don't put together a complete program, we might be doing ourselves and the athlete a disservice. And part of that is appreciating what the front shoulder does in hitting. How do we best prepare an athlete for an unpredictable open chain activity moment? I thought this was a great quote. Although weight-bearing closed chain positions do occur in sports, it's more common in sport for the hand to move freely in space against varying external loads. Hitting. It's hitting. It's fielding. It's everything that's away from, diving into first base, overthrow, push yourself up, rotate, get going. Same thing on defense. Be able to jump up. Find that ground-based activity. But as you look at these images here, let's take a look on the left. You got G-Man. Watch his celebration. That's his lead shoulder here. He rips it through every time. He hits 30 home runs, he's going to do it. He hits 50 home runs, he's going to do it. That's just his celebration and the violence. Watch the middle. Here comes Brandon Lau sliding in. Now that's his backside hitting, but call it player X. It could be his front side. Think of the varying external loads that are taking place. What's going on through this range of motion? What if his hand hooks the catcher? What if he's not wearing the mitt on the left hand and his hand gets stuck on the plate? There's a million different things that can happen, and we have to think about that. And then Brandon Lau again on the right. This is where I thought varying external loads was best when you think about the hitter's shoulder. Look at the bat as he flails. He's beaten on the Sabathia pitch. A lot of people were in this Hall of Fame career. And think of how that bat is really swinging through and what his shoulder's doing. You got the pec and the bicep are coming in to slow that down. But it doesn't mean repetitive activity, because he still has that posterior force and a load before he realizes that he's out in front of this pitch. So prior to starting, operative, non-operative, doesn't matter. We need to go through that injury and surgical history. Is it a surgical history before this injury? I know in-house, I was talking to our coordinator, Aaron, and Joel. He and I haven't talked, but, talking to Aaron, somebody Joel's going to work with. We have a guy who had a posterior labral repair last year, and he just had to go through anterior, minor league player. So you need to get these surgical histories and understand what's going on. What was the injury? What sent them to you? What do you want to address? What is the total body telling you? Looking at the shoulder anatomy, what do you know about it? Again, if there was a previous history, what has changed anatomically? If nothing has changed, just looking at them, what anatomy needs to be addressed? What forces are driving them? What weaknesses have you found? Now, again, like we talked about, finding that weakness doesn't mean that you don't work away from that area. Hammering that area, you could be missing something a mile away. But again, that physical exam is going to play into it. And what's been done to that point? Does immobilization matter? Some papers talk about, immobilization. Some physicians, some clinicians believe immobilization, 30 degrees, keep them in that. Some say that moving quickly will help. Again, getting with your physician, all your clinicians, finding out what's going on will help you make that decision. There's no official cookbook. Everybody's got a different recipe. And you need to prepare your athletes. Success rates of surgical versus conservative approaches. Prep them. Be honest with them. Your throwers, much lower rate of return. We know that, and it stinks. It stinks when you say that. You don't prep them for failure, but you're like, look, this is the realistic approach. This is why we might go non-operative. Success rate of position players, front shoulder hitting, a lot better. The amazing ones are the ones that are non-throwing and back shoulder. So like we talked about at Kiermaier. So there are certain rates and success stories. Again, surgical planning, labrum versus rotator cuff. What are we getting into? How do we want to take them from beginning to end? Not that you write a calendar day one and you don't veer from it. That you can't do. But how do you know you want to prepare this person? What are the things they have to do? Because by the time you give them back to the baseball side, it's almost like starting over again. Because again, although the forces of the lead shoulder are lower with hitting than they are with pitching, the repetition is still high. Again, position player versus pitcher catcher. I know some National League athletic trainers are out there. Hitting is a part of what their pitchers do. Now you can bunt, and I know you can make adjustments, but that doesn't mean that that's what the manager wants to hear. Oh, he can bunt all year. it doesn't play that way if you're early in the game. Your calendar, preseason, in-season, postseason, that all factors into it. And your overall athlete concerns, conditioning, dietary, work ethic. How do they take care of themselves? How can you take care of them? How do you fold in your other people in the process to help them that can help you be a better clinician, better strength coach, better athletic trainer, better physical therapist while they help with the other areas? So again, in the labrum, you're thinking of the type. What are you dealing with? Could you be more aggressive with a debridement? If your surgeon says so, absolutely. Just because there was a debridement doesn't mean you have to be aggressive, because if the joint is irritated or you are dealing, as Nick alluded to, with somebody who is just upper trap dominant and they do not have proper scapular motion rhythm, then it doesn't matter how easy the surgery was, you have to start at the ground level. You know, you don't build a house from the roof down, you build it from the ground up. So think in phases. You know, about 0 to 3 weeks, obviously you've got to minimize pain, inflammation. You've got to get them to where they feel comfortable. 3 weeks to start passive range of motion. Everybody's different. 0 to 3. Doesn't mean you start at 3 weeks if they're having extreme discomfort. If they're having extreme discomfort, they might need to go back and see the surgeon. It could be that they're just responding poorly, they're not great with pain, or there's an issue. But they should be able to start in that area. You're going to move on to your active. You're going to regain normal motion. You're going to increase strength. And that's all going to be done different for everybody. Just because you have 2 people that went into surgery on the same day, just because Schwarzenegger can start exercises on one day doesn't mean Stallone can. Stallone beat the hell out of Ivan Drago. I bet he can start before Schwarzenegger. Just my guess. Phase 3, 4 months tee and throwing, front side. Again, this is what Stan and I were talking about. Doesn't mean that at 4 months they're ready to go, because if you start them with a wiffle ball bat, and they can't swing a wiffle ball bat, or you see them, I know Dr. Elattrache and I were talking, and they've got bad ground up, bucket stepping, or they're just not willing to do anything that's going to expose that front shoulder, they're not ready at 4 months. Doesn't mean you start day 1 of rehab, but you have to go back and assess where they are. Is it mental? Is it physical? Is it strength? And all those are all the things you need to explore with the front side shoulder before we put them back into activity. Rotator cuff, we'll just breeze through. Just basically, you know, we know in the older population, dislocations, traumatic episodes can cause a lot of rotator cuff damage. Doesn't mean in the younger population you won't see that. I believe Dr. Elattrache kind of talked about, you know, the wear and tear of the cuff, what you can find, and especially because we're dealing with the highest level athletes, the ones they've been the best athlete. A lot of them have played multiple sports either at high school, and then were high rounders for us, where multiple sport athletes went on to high level college. You know, we all see even the NAIA ones. They may not have gone to the big college, but they were still the best athletes. So we're going to find wear and tear, but it doesn't change your phases. Your phases still need to go. You're not going to skip anything. But by the time you get to phase 5, you better make sure that you have your strength, your motion. You better have made sure they have normal range of motion. Because if you don't do great with normal motion and you say, they'll get it actively, then you may not get the strength you're looking for. If you don't have the strength you're looking for, hitting progression is going to have to stop. And instead of being ready at 6.5 months, it might be 8 or 9 months because you didn't want to take the extra week or 2 on the front side. Always let anatomy be your guide and your surgeon, whether it's operative or non-operative, discussing, you know, the diagnostics Dr. Elattrache spoke about, whether it's speaking, as Nick spoke about, with the entire chain. Let everything be your guide before you progress. Because as simple as the front side shoulder feels, thinking of the 500 plus pounds driving, seeing the short gifts that we threw out there, seeing a sublux shoulder diving back into a base, all those things are something they have to do. It's not the ability to just go hit a ball off a tee and hit flip. It's how they're doing it. It's the intensity with which they're doing it. And it's all the other activities. We wouldn't put somebody coming off ACL surgery without running them through sliding drills. Well, we certainly need to run those same type of drills for the upper extremity, which would be defensive work and sliding into base. Very simple exercises here, obviously, active assisted, passive range of motion. Again, these are all things that we're going to do, but even a post-operative, these can be non-operative managements. But we know, especially if we're going to deal with the posterior, and if they're coming out of surgery with a posterior repair, we know we're going to be limited internal range of motion. Everything's different. But the whole point of this is that even non-operative management can go through these exercises to find your pain-free range of motion. There's nothing wrong with doing this for a day or 2 or 3. As much as the athlete may not like it, there's a reason you're doing it. And I think we have to appreciate that, because skipping some of these steps, we may find that they're not exactly where they need to be. Shoulder isometrics, anybody who's done rehab with a player will tell you they can't stand it, especially if you're dealing with somebody who thinks they can speed up their timetable. You know, it's important to read that top portion, which is initiate muscle strength, facilitate reabsorption of the cellular exudate and bleeding, and improve static function. At the end of the day, muscle tension without changing of joint angle. We don't want to irritate an already irritated area, but at the same point, we don't want to lose strength. We want to at least maintain. Not the shoulder isometric is going to, take you over the mountain. But at least if there's atrophy, you can get it going. We don't want to let them be sloppy, as I'm sitting right now. You want your good posture. As Nick spoke about, you want to get your hips underneath of you. You can do it standing, depending on who they are. You can do it sitting. But whatever you do, you need to get them going and make sure that all the steps are being taken. Because just jumping through this again, you could end up going backwards. You don't want that. Scapular strength, tremendously important. Tremendously important. This is what I was talking about. I don't think we could get where we are without the scapular strength, without the anchor of the rotator cuff. All right. Think of just simple retraction. If you can get retraction, protraction, even while you're splinted, great. If you can get them even in a non-operative sense to understand that, or scapular clocks, to get them to understand their motions. Because as we can see below, if normal scapular movements are disrupted by abnormal scapular muscle firing patterns, weakness, fatigue, injury, the shoulder complex functions less efficiently and injury risk increases. Well, if we've either A, come out of surgery where they already have injury and we need to understand the rate of reoccurrence, or we're trying to prevent a rate of reoccurrence, then we need to appreciate what the scap is doing, what the mobility is, how the range of motion looks, and what's the strength, right? Run them through an activity that's going to fatigue them. That could be something as simple as swinging a bat once they've been able to pass all the manual. Scap manual, again, you get your serratus involved. You can go a million different directions, but whatever you're doing, it needs to work in concert with what you're trying to do, which at the end of the day is open chain. Simple on the left. All the ranges of motion need to be addressed. If you see those and you can't accomplish those, then there's no need to move on. Look, I get it. There's going to be times where we're going to have somebody who's active and we're not going to be able to pull them and put them on the IL. I've authored 1,000 injury reports and none of them have had good news. And I understand that failure is going to happen, but we need to be able to appreciate those motions when we're going through shoulder work to get us where we need to be. Shoulder mobility, so important. I know that sounds so amazingly simple, but it's something that has to play into the rehab. It has to play into the hitter's shoulder. Mobility may not be there despite what we think is functional, functional active, functional hitting. They might be hitting, but you get them in the athletic training room, or you get them into the clinic as a PT or strength coach. And that's a lot of times where your strength coaches and athletic trainers work hand in hand. They may say, hey, he was really struggling to get his shoulder going in the weight room. And you get them in the athletic training room and you realize there's an issue. Well, obviously by the time they're in rehab, everybody's worked together on the performance side, but we need to make sure there's pain-free range of motion on the front side. We can't afford to get into a compensation world. So clear soft tissue restrictions, soft tissue mobilizations, you want to throw the house at them again, because by the time you put the bat in the hand, you don't want to have to go backwards. Shoulder strength, right? The easy part. Lamont, Sanford & Son, for those who don't know. So considerations during strength. Here we go, the force coupling. That's what we were talking about. So on the left, look at the rotator cuff. It's pulling in. It's pulling towards the glenoid. What's the deltoid doing? It wants to add an abduct, superior orientation. If you're not working in concert, by the time you get to the right with the periscapular musculature, and the one on the right looks pretty familiar. It looks like a high slot finish while swinging a bat. So again, that gets into what Dr. Elattrache talked about when you're talking about the forces. If those aren't working in concert, you really don't have a chance to succeed. Doesn't mean you will succeed. If there is such a large lesion anteriorly, but thinking of how the couplings work and what you're trying to accomplish, this all needs to be thought about during your program. There's a million ways to accomplish this. And these are just the shoulder programs. There's so many other things that have to go into it, such as, you can put the bat in the hand and run them through different ranges of motion. Doesn't matter what your front shoulder is. You can get them in a distracted position, and you want to work where the rotator cuff is actually in that adduction angle, and you want to try and strengthen them. But maybe even using the pitcher's tubing. We know it's been popularized through our friends. I think the first time I'd seen it was honestly through Driveline, and we've seen it through Trevor Bauer, and I think we all have one now. I love it personally. It's basically the version 2.0, 3.0, whatever you want to call it, body blade, where instead of a single plane movement, you're able to actually get it moving, and it takes the arm through different stresses as it takes you through the range of motion. So if they want to go through D2, as they come back, it's not just moving in a single plane, it's actually pulling them through different ranges. Those are important, supplementation exercises before you get them going. It could be tubing, it could be that. It could be anything that's going to give them an unstable surface. So a hitter's progression on the front side. Be ready to take a step back every day and adjust. Be ready for failure. We're all ready to fail. We have to remember, as the bat rotates around the front side of the body, it has the opportunity to surpass the soft tissue structures, right? If you're post-operative, you need to keep that in mind. If you're non-operative management, you need to keep that in mind, because if those are the structures and you push them to the brink, we may send them to, bright lights and cold steel. We have to remember what the upper extremity musculature has shown through the EMG studies, which is that in space, okay? The posterior forces can change. Depends on the location of the pitch. So we want to make sure that the hand is able to move freely with varying external loads. Listen for the feedback. Repeat, repeat, repeat. This is something that, I was speaking with our rehab coordinator, Joel Smith, about, and you can see how it works. Just a standard hitting progression. It doesn't mean that everybody goes through this. So somebody just has a little, obviously there's shades of gray, but we're talking a true hitting progression. We're talking somebody from point A to point B, all right? Why a bat progression? Because if they can't use a wiffle ball bat, why progress them? If they can't use a fungo properly, if they can't use a regular bat, you move them to dry and T. You want to keep progressing. If you jump too quickly, and I'm not saying that we don't have extremely strong people that can make it happen, but by and large, failures are met. So why not take the extra time? Everything can be adjusted. One thing you can't do, no matter what's out there, no matter who is advertising what, one thing you can never do is get back time. When we get that feature, it's going to be an amazing world. But until then, we want to start making sure that we're taking our time, because once you can launch and you throw the rocket boosters on, it's a great feeling. So there isn't really an abundant amount of published research regarding the batter's shoulder. Consistently, what has been published, 5 to 6 months return to full sport. I can't see it any faster. I really can't. I don't think cutting corners matters. We talked about that. A lot of this has been the anterior-based work, but the posterior-based has also backed that up. It doesn't mean you can't get longer because of where you are. So if you're, if it's performed and you're supposed to start hitting progression in November, you can start hitting progression in December. So it might take you to 7 months, but really you lost no time. Are there concerns regarding posterior labrum operative management? What I've seen, basically development of the postoperative stiffness. Dr. Elattrache might be able to touch on this a little more. But again, that seems to be one of the main ones, besides just generalized concerns and fears of it happening again, stepping in the bucket and not really getting into their mechanics. From the research, you can see here up top, throwing arm versus non-throwing arm. The criterion, bank heart, arthroscopic repair, first-time dislocation. You can see the rate of return for pitchers. Now, that is both front dominant and non-dominant, and that's 89. We can assume that dip in success is coming from the throwing side. But look at your catchers and infielders. Now, they didn't really specify what infielders were, if there were no outfielders, if that encompasses everybody. But 100%, 95% front shoulder. Average return play was 8.4 months. I'm believing a lot of that is the pitchers on the dominant side, which is raising that average. You can see down below, again, small sample sizes. That's how this area works. There's not a ton. 11 of the 12 that were surgical returned to the previous level of batting. The one that wasn't had other medical issues that were outliers. Noted all had normal range of motion when they returned to play, even the one who didn't return to a previous level. And here you see the posterior labral tears among baseball players. All positions captured. 32 sample size. That was the biggest I had seen. 94% return to play. So 8 of them were from batting. So again, 94% return to play, which is, again, we see that on the front side. There is a high success. Not great success on the dominant side. Throwing, non-dominant, great. 61% at previous level. Now that can be assumed a lower return for the pitcher. But at our level, return to play at previous level or higher is the goal and expectation. So when I showed you that slide earlier of the player diving back in and subluxing his left shoulder, he technically would get check marked because he did get back to play. But he never returned to his previous level at higher. Again, like I said, it was an outlier for other reasons, so we'll never know so much about the shoulder. But when it comes to research, we do understand that those numbers can get kind of check marked a little different than we see different in the outside training room. Don't be afraid to adjust. Plan for the long haul. Learn as much as you can about your athletes. Listen to them. And rehab is a team effort. Injuries happen to everybody. Lord knows if we've all been on, all of us here, we've all stood on the field. We know injury is going to happen. We do the best we can. I appreciate the time. Thanks to Stan for putting this on. Thanks to Nancy. And appreciate everybody's listening.
Great, Joe. Battered shoulder is pretty interesting when you start looking at the research, of which there's hardly any. The study that you talked about that had the biggest sample sizes was 51, and it was from South Korea, who did a really good job on the study. We've looked at number of shoulder dislocations in baseball over the last 8 years, and we found 177 of them. So this is not unusual. It is, Joe was talking about dominant pitchers, dominant side pitchers, you know, I would bet 0% come back, because if you have to have a Bankart, you lose. The whole purpose of that surgery is to restrict external rotation and abduction. So you can't get any velocity behind that. So it's hard to get back. Nancy, do we have Neal back?
Yes, we're working on that.
Okay, okay. We'll ask Nick some questions from the audience here. From the pelvic retraining exercises, 90-90 abduction drawback, what coaching cues do you use for the athlete? Should they feel the adduction and hamstring pulling in on the hip posterior, or not their glutes?
So yes, hamstring adductor is what we want to feel on the hip that's pulling back and in. So typically my cueing has a lot to do with starting the system properly. So making sure that we've already fed the system right, hamstring and adductors are on, and that's what's going to feed us to activate those muscles farther. So if we've started with the wrong activation, the glutes are firing, abdominals are firing, the back is firing, you're just not going to get the proper activation patterns to happen. It depends on what they're having trouble doing. So if they're overactivating their obliques, for example, side bending, a lot of times they'll jet over to the side. then we're going to try to force a little bit more of a adduction pullback, but in conjunction with the right glute. So for my cueing for the hamstring and adductor, it's feel your foot slide down the wall or your calf pull in towards the hamstring, and then have that knee, because the ball's in between the knees, push a little bit into the ball, and hopefully that biases that. And then before we do our shift, put the opposite leg into the wall to fire the glute. So what we're getting is backside drive activation, which is our right glute, and then pull back into our front side, which is the adductor, and we bias the system previous to moving. But manual cueing is also a good way to go. And then we restart all the time. Okay, pull in with the adductor. Do you feel that? No, it's a compensation. Reset, restart the whole system. Let's feed it again. And that takes a lot of time sitting on the wall and working through this, because it's a neurological ability to recruit the proper muscles and not recruit the wrong ones. And likely they've been recruiting the wrong ones for a really long time. So it's going to take a long time to feel what we're trying to accomplish and then be able to reproduce it.
Good. Neal, you had a lot of time with Frank Jobe. I was fortunate enough to spend some time with Frank Jobe. And when we used to do the risk assessments on the draft, he would ask me all these things about what we looked at as risk. And his famous line was always, pick an elbow, never a shoulder. And maybe you can talk a little bit about the outcomes of labral repairs with no other problems, normal rotator cuff, a normal cartilage, etc., versus ones with have 50% rotator cuff tears, and how those outcomes have improved.
Yeah, I think that gets to what we were talking about patient selection, and I don't mean selecting this person versus that person. It's knowing what else is going on inside the shoulder to really determine what the source of problem and pain is. And if you look at somebody that is getting operated on for a labrum tear, and we saw what our results were on the KJOC scores, we saw really dismal results with superior labral repairs. So when we were first looking at the KJOC score, we saw about a 57% good and excellent result on the KJOC score. And we were looking at the published reports of labral repairs, and they were way up, much higher than what our KJOC scores were. And so that prompted us to go back and look and see what was happening with these players. And so one of the strengths of a patient-reported outcome score is that you really get a good idea of how that player is functioning. It doesn't matter if they've scored off the charts on an ASCS score. If that guy can't pitch, there's something not matching up. So our first indication that something wasn't quite matching up with what was the difference in the patient outcome scores versus the other scores that we had in our armamentarium, what was being published. So they were useless. So when we went back and saw, okay, why is this player with this labral repair not able to pitch, but he's scoring off the charts with all these other things? And we looked at what are the concomitant problems that are going on. And by and large, what we found was that if you had rotator cuff pathology greater than 50% rotator cuff tear and had a labral repair, your chances of coming back were less than 20%. And so if you took all comers with a labral repair that didn't have significant rotator cuff pathology, your chances of coming back to play were 80%. And so if you put those two groups together, that's why we ended up with a 57% good or excellent result on the patient-reported outcome. So the rotator cuff is a huge pain generator in these guys. It's a huge problem that's very difficult to fix. We're getting better at it, not because we're getting to be better surgeons. We're knowing what parts of the rotator cuff need to be fixed and which ones you leave alone. And so you can't operate on them like you would a civilian with a partial thickness cuff tear. They'll never get their arm to, like you were saying with the instability problems, they'll never get their arm to the positions they need to generate velocity. So I look at those two critical points, the attachment in the back and the attachment in the front, the cable attachments. Those are anatomically visible points. And if that's violated, what's happening is that's a dynamic stabilizer of the head. And so I'll just fix that part if it's violated. Now, how do I know who to do that on? It's important to have good longitudinal exams. So if somebody comes into you at the beginning of the season, you do their preseason physical, they've got good rotator cuff strength, no pain. All of a sudden, they end up with a sore shoulder with good strength. You know that dynamically their cables are still attached. If all of a sudden they have weakness on external rotation, you numb them up, you take the pain away, and they're still weak, you know that now they've violated a critical part of the cuff. So long answer to your question, rotator cuff is a big problem. That's going to determine how you do with anything else you do in the shoulder, is the status of the cuff.
Yeah, I think that this is really important because when you look at the studies, they're all over the place on return to play and return to previous levels. Some are very, very low. Some are what I think probably are ridiculously high. And a lot of times they don't really identify the specifics of the pathology. Also, on a follow-up question to that is the idea that you talk about with the knotless sutures and the fact of not pulling the capsule. I think we saw that a lot 10 years ago where people were tightening, were repairing the labrum, but also tightening the anterior or even posterior capsule. And these were the guys who came back but couldn't perform because they were throwing 6 or 7 miles per hour less than what they were.
Yeah, once again, you have to keep their function in mind and what they're going to have to do that makes it possible for them to be able to play at that level. You were one of the first ones to point out to me. I said, look, you decrease external rotation. For every degree of external rotation, that's a mile an hour that's coming off this guy. It's the difference between him making lunch money and making the kind of living that he's going to make is those 3 miles an hour. So you got to be very careful in any motion that you limit in the thrower.
Nancy, how about a question from the group?
Okay. For posterior glenohumeral subluxation and hitter's front shoulder, I feel like you can do all the traditional shoulder stability exercises that you want, but do you have any recommendations for exercises that will better prepare the hitter's shoulder for the speed and load that is put on the shoulder during the swing?
I know that's a difficult one, just because, like we talked about, we're dealing with the stability and what, like I said, the EMG studies have shown, which is that the muscles are really working in proprioception. They're working to get the bat to the ball. It's basically survival mode at the plate. So I don't know if there's one over the other versus just taking them through variant ranges of motion. I read some interesting stuff along the way, and it's hard to include everything, but some of it was that are more skilled hitters just better at producing forces than amateur hitters. So basically, when you have that stronger base, is it the better you are at hitting, actually creating greater forces just because you're more whole, I guess, or more efficient, for lack of a better term. So the more efficient you are, you take a strong base, you take somebody who understands hip separation, you take somebody who really can fire through, store the kinetic energy, and get going. To answer your question, I don't know if there is really some high-level exercise it's magic. I think exactly what the question said. Do all the shoulder exercises in the world, but I think the one difference for me is taking them, maybe adding the closed chain, taking them open chain, but then moving them through the ranges of motion. I think maybe that's something we all need to look into, is just instead of saying, okay, we're going to work here, 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 because they're going to finish, it's making them more active through the range of motion and picking those different areas where you're going to surprise them with perturbation, then maybe scripting it where their body's able to compensate. I don't know if that really answers the question, but I don't think there's anything where you're saying tubing versus shoulder tubing versus manuals versus plyometrics.
Nick?
Just a thought. So I would look at this person that has that outside pitch, that had to take their hand off the bat, that caused this posterior impingement problem or exacerbated something that might have been already building up over time. What we try to do is train them to get into an adaptable position where now, even if they're, let's say, fooled or reaching for something that's way outside of their range, they're able to now create this rotational torque and forces through maybe the hips instead of the shoulder. Maybe the obliques are able to hold them in a position that doesn't get them into this extension piece way back here. So I would say, in terms of looking at how their lower half is functioning and what position that's putting them in, might have a chance to get them more adaptable when they are out of their normal rhythm, out of balance, fooled slightly. That would be where I would think about looking.
Good. Nancy?
Dr. Elatrache, with the capsular tears, are they typically chronic, or do you see them more often with an acute episode? I currently have an individual that reported a pop on one throw, and imaging revealed a tear in the inferior capsule as well as the subscap tendon. Have you seen many of these respond positively with conservative management and or biologics?
I don't know what the denominator is, Nancy. So there may be some out there that are doing okay, but the ones I've seen are the ones that they'll remember an episode, an incident where suddenly their shoulder hurt a lot, and it's usually up in the anterior aspect of the shoulder and axilla, and then every time they try to push their effort or velocity back up to where it was, they have a lot of trouble. The kid that I showed the MRI on, he actually had an episode like that, rested the shoulder and got biologics. And 4 weeks later, he was coming back and went through sort of an accelerated throwing program, but they never really got him up to full effort, max effort off the mound. But his first game, he ended up dislocating through the tear and buttonholing through the tear just by pitching. It wasn't a traumatic injury. So I think that you might be getting some gradual attenuation, but that final insult rips the capsule. The ones I've seen, I mean, they've all failed when they were trying to come back. We tried to treat, they all had gone through a conservative management program. Some of them were undiagnosed and went through it. And then when you go back and look at the other MRIs, the MRI scans previously, you can see, okay, he had a capsular tear at the beginning that he never came back from. So for me, it's a bad actor. This subscap is usually not structurally detached from the humerus. It's swollen because of the stress in it. So you usually don't have to do anything to the subscap. I just, like I said, I'm only seeing the numerator. I don't know how many would do okay. My suspicion is that this is a bad injury that they can't come back from.
Nancy?
All right, Nick, could you explain your assessment system when you see a new patient? Would you check all PRI tests continuum, or is there any baseball specific assessments other than PRI concept?
I don't do any PRI evaluation anymore. Not because there's anything wrong with them, but because I find that I just learn more when I watch people move. So typically my movement assessments are much more just functional movement based. Lunges, I mean, honestly, that hands on the wall is a place that I love to start. It tells me where people compensations are and what's going to happen when I tell them to raise their arms. Standard flexion and abduction, overhead, shows me what their strategies are for scapular motion. Just basic step ups and body squats. All that gives me a basic idea of how they move, because I think that we've seen if we look at something in the eyes of posture restoration, is it changes from day to day. And that first time I've seen someone, it doesn't necessarily indicate their overall picture if they're shifted into one pattern or the other. I want to see how they functionally are able to move from one side of the body to the other in just basic functional movement. And then if I really can't find anything, which is yet to happen in basic motion patterns, then I can dive into the PRI-based evaluation techniques and see if I can figure out a shift that I'm just not detecting based on basic motion. But you can see the pelvis is stuck off to one side and they're not reciprocating by someone walking in the room or just doing half lunges down the track. And same thing with the shoulder blade, just arms overhead in front or on the side is really a lot of information for me to start. And then every day in treatment is evaluation. So where are we going and what problems are we having? What's happening with the obliques is something that I learn much later as I watch people move. So that's like the last thing that I'm evaluating. So again, like PRI evaluation, I think is amazing. I just have found that I end up getting more out of the functional movement to start, and maybe I can dive into the evaluation process more, later if I need to fine tune.
Okay, we're kind of running out of time here, but this is to the group, maybe to Joe specifically. We've had multiple questions on shoulder range of motion measurements, which always seems to be an interesting topic to me. Kevin Wilk has done such great work with Tampa Bay and doing longitudinal studies on range of motion, and it sort of changed over the years that internal rotation deficit left to right, anything over 15 degrees was disaster. And then we got into total range of motion, 5 degrees over, you're unstable. And then flexion came in now. Flexion and too much external rotation causes problems. The questions are like, what range of motion assessment do you use, Joe? And follow up with Dr. Elattrache on when you see somebody in the clinic, where are you looking in regards to internal rotation deficits, et cetera? Joe?
Our total range of motion are performed actually our sports science. So like we talked about the entire team kind of jumping in. So I'd lie to you. We kind of throw like an algorithm together. So I don't know if we're married necessarily to one versus the other. He has red flags, whether it's 15, whether it's 10. We take a lot of things into account versus abduction versus strength. So, I would say that a lot of that is an in-house thing at this point in time. We're not living necessarily completely off of just the literature saying, if you're 5 degrees, if you're 10 degrees, because, looking total range of motion, we're also looking in there as we'll do the ultrasound from a retroversion standpoint. So a lot of times that will actually take it and kick it back and saying, well, because of this, it maybe not that much of a concern. So from a norm standpoint, I don't know if I'm going to sell a complete number. I know what the literature says, and I know we believe in it, but I don't know if I can sit here and tell you that the Rays believe in this, because I think we put so much else into it that, obviously if we're looking, you want to say 15, you want to say 20, yeah, we're going to run some red flags up there, but, it's a individuality. I'd say that's honestly the way that I do believe in it.
Neal, when you see a patient in your first exam, what stock do you put in range of motion, especially from an internal rotation situation?
You know, I'm much less focused on just internal rotation than I used to be. Total arc to me, I mean, is means a lot, and it's not increase in total arc. I get worried when the throwing side has a decrease in motion, and those are the ones that I see that are that I compare that to their films and their MRI scan, and all too often those are the ones that I see with the posterior glenoid dysplasia and some of the edema and the tuberosity, because they're banging that humeral head and the tuberosity when they try to get back to generate speed. And so I'm not real big on the internal rotation deficit, because I think most of it is bony and it's adaptive. And I look at compensatory increase in external rotation. Usually it's reasonable compared to the other side, but the guys that have the total arc of motion loss, those are the ones I really worry about.
Nick, what about you?
Well, I mean, obviously I'm talking about in this talk a lot of kinetic chain and full body. So I'd love to find a way to somehow measure dynamic range of motion. If the shoulder blade is stuck back, you gotta get a bunch of internal rotation to get the ball to go forward. If the scapula can protract, we don't need as much. It's just kind of, you can kind of picture that. And then the position of the shoulder blade affects how much external rotation we can get before we get some kind of impingement. So if we're in the cocking phase and we're somehow slightly anteriorly tilted because of maybe some kind of upper trap dominance, then that's going to change our ability to externally rotate. So I mean, I don't have the answers, other than I feel like the way where the shoulder blade is makes so much difference in measuring range of motion, and we know that by how stringent we try to be in measuring range of motion with like a pinned scapula, you know, in that neutral kind of range, but that's not how it necessarily works, right? So I'd love to find a way to measure it dynamically somehow as someone throws, and see how that correlates. But I think that there is something to range of motion and the position of the scapula that sometimes we miss by just measuring in one locked back position of the scapula.
Yeah, I gotta agree with that. I've seen this. I think sometimes we think the humerus rides on the glenoid, when I think the glenoid rides on the humerus. And when you get scapular stabilization and the scapula moving correctly, and I got to tell you, 25 years in baseball, and I believe that I was teaching scapular exercises incorrectly, and really not getting much change. Because the most frustrating thing is you see a guy in spring training that has a winging scapula, and you say, well, we got to fix that. At the end of the year, he still has a winging scapula. I mean, so we don't have an impact on it. And I think one of the things that we have to look at is this, you know, the Kibler concept of scapular dyskinesia may be the first and most important step in regards to rehab of the shoulder, but also the whole kinetic chain. I kind of seen this. We've had a patient come in, a major league patient come in with it from a referral saying he has internal rotation deficit, and we need to increase that. I think we found that the sleeper stretch is not a very good one. It's a better way to stretch the posterior capsule. But I also think that on the patient that we saw, we never stretched him one time. Nick didn't stretch him one time. We did nothing but scapular stabilization, and he increased 15 or 20 degrees on internal rotation. The doctor called us and said, what a great job on doing your internal rotation. Didn't work with it one bit, but the scapula was now efficient in staying up with the head of the humerus. So something to think about. Okay, great. Listen, thank you very much. I know we went kind of over, but you know, I guess selfishly I would have sat here 2 more hours. Dr. Elattrache, thank you for your time.
Thanks,
and Joe and Nick, good stuff on rehab. Just a couple things as we close out. I'll see you guys later. You guys can go. We're going to share. I just want to talk about next week. This is our program for next week. It's going to be on the hamstrings. This is one of the ones that the group really wanted to do on hamstrings. Dr. Kalichi Okura from Henry Ford Hospital in Detroit was our author on our hamstring study that was published last year using the epidemiology in regards to hamstrings being the #1 injury in baseball by a lot. Holly Silvers is a PT and a researcher from Santa Monica who's going to be talking about prevention, and Normatex, they did a study with the Angels that's important, and Dr. Jacob Selim is a physical medicine rehab. We're going to talk about orthobiologics and PRP and hamstring injuries and what the latest research is on that. So thank you very much. You got two things you guys need to do. One is there's the poll at the end that we'd like you to take and give us more feedback. Also for CEUs, remember to do the survey. If you don't do it right after, you'll get a email 24 hours later to be able to do it. It's really important to be able to get that survey done for CEUs. Okay, thank you very much, and we'll see you next Wednesday, same time, same place. Appreciate it. We're going to leave this on for a while so people can do the poll. Thank you very much.